side of the room as well as the 2 back doors. Toilets are outside. And we would like us to start and stay on time today. So there's quite a few of changes on our program, and we would all like to go and enjoy our day. So the first, excuse me, just quickly make sure. Neo? We can start now? Okay, all right. All right, ladies and gentlemen, we're going to be starting with our first presenter today. So our first presenter is one of our, or our first facilitator for today. Apologies. Now I forgot what I'm supposed to do. You guys will have to guide me sometimes because I completely forgot what I'm supposed to be doing in here. So ladies and gentlemen, our first facilitator for the day is Ms. Neo Lebitso from the Sedibeng district. So please give her a round of applause as she comes up. Thank you.
Dumelang, Sanbonani, Abusheni, Nda. This is your favorite midwife, Neo Libito, working here in Sedibeng district at Johan Heinz Clinic. So there will be a few changes today, colleagues, with regards to the program. Remember yesterday there was a lady that needed to present online and they couldn't due to technicalities. So we're gonna start with her. Is she already connected? She's been connected. Okay. All right, so while we wait for her to be connected, I'm just going to wait for people to settle down and take their seats. All right, thank you. Oh, by the way, colleagues, you look absolutely stunning today. Can we please give ourselves a round of applause? So we're going to start with triple elimination that will be done by Ms. Koza, if she is connected. Okay, DJ, can you please go back while we are waiting for Ms. Koza? Please. Ms. Kosa, can you hear us?
No, it's not moving from my side. I can't move. Yes, I can hear you, but I can't move. They can't move. The slides can't move from my side.
They can't move from her side. Okay, we'll try and do it from our side.
Yeah, it's okay.
All right, thank you so much, Ms. Kosa.
Yes, it's
Over to
okay. It's
you.
moving. Can I start? Oh, okay. Thank you, Tabang. And good morning, colleagues, and thank you everyone for letting me this opportunity to present. I'm Gulani Kosa from National Department of Health. I'm responsible for the vertical transmission program. So I will be presenting to you the elimination of vertical transmission of HIV, syphilis, and hepatitis B. Oh, I moved this. Okay, so to start with the background, just to remind colleagues that may not be aware that we have changed the name from the previous PMTCT, and now is called the Vertical Transmission Prevention VTP program. And also as a background to acknowledge that the infections that are acquired during pregnancy, they have a major contribution to the major causes of the perinatal morbidity and mortality, and they also lead to our IUD, the intrauterine death and stillbirth, and also causing the premature birth and fetal growth restriction. So we are trying to reduce these transmissions, and that are common in South Africa is HIV, syphilis, TB, hepatitis B, malaria, and listeriosis. But for now, we only focus mostly on the three infections, which is HIV, syphilis, and hepatitis B. Because also we have noticed that most of the infections that are acquired early in the gestational age and during pregnancy, they are more severe and more damaging than if it's reactivation. So we have, in the program, we have 4 pillars that are guiding us to manage the program. Pillar 1 to 4. Pillar 1, where it's talking to the prevention of the transmittable infections among women at the childbearing age, where the interventions here are the testing, the screening, and the prophylaxis that we are giving to protect our women not to get the infections, referring to all these 3 infections that I will be presenting. our guideline how to manage the unsuppressed viral load before they deliver. Next slide, please. Okay, so as I said, after antenatal, if they were all suppressed, now we're going to repeat it during delivery. So all our pregnant women that are HIV positive, when they come for delivery, we need to collect a viral load during labor and delivery. We can collect it during labor or immediately after delivery, but they should have a viral load during that period that we are going to monitor and assist us to give our infants the prophylaxis. And then we're going to repeat the same viral load after delivery at 6 months after delivery. So 6 months postnatally, we're also going to collect the viral load. Here for every woman, whether they are breastfeeding or not breastfeeding, this first 6 months, we collect viral load, all of them. And remember to put the EGK code as expected. And when they are, if the woman decides to continue breastfeeding, it means we're going to monitor their viral load every 6 months. But for those who are not breastfeeding, it means we will end at the first 6 months. And their viral load schedule will be aligned with their children's EPI visit or schedule. Next slide, please. This is just a reminder, as I said, all the viral loads that are collected during pregnancy, delivery, and postnatal needs to be identified so that it does not get rejected. We need to put EGK code. Currently, we have 2 EGK code, which is C# PMTCT and C# delivery, but we are working on that to update those so they will be different. I think we're still working on that, but currently we still continue with these 2 that are there to prevent the rejection from lab and so that we can monitor it very well. Next slide, please. Okay, as you can remember, colleagues, I said when we retest and at some point they test negative, we need to offer our pregnant and breastfeeding women PrEP so that we continue reducing this transmission rate. So we also need to continue giving them, and we report this. So the guideline allows us, we do have PrEP guideline, and VTP guideline allows us to give the pregnant and breastfeeding women PrEP, and we need to make sure that they have tested. We need to exclude HIV testing. We continue the adherence, and we monitor their EGFR and offer the HIV testing every 3 months here. It won't be every bank visit as I indicated initially. When they are on PrEP, they need to be retested every 3 months. But if they are not on PrEP, that's when we retest them every bank visit so that we reduce the transmission rate. Next slide, please. These are just PrEP job aids that are in the guideline. We can use them to when we want to initiate, we screen them, we can guide us with all the algorithms. So I just wanted to share, we can refer these ones on our guidelines, is there to show what to do and how to go about all initiating PrEP for pregnant and breastfeeding women. Next slide. Okay, so here I want to talk about the Global Alliance to End AIDS in Children by 2030. So you know, when we talk VTP, we also need to talk about the Global Alliance because this is a multi-sectoral vehicle to assist us to eliminate HIV, and is part of our intervention that we are using to address all these gaps that we have identified. And I know Gauteng also has launched their own a provincial plan. So this is what we need to focus on. As we realize from Pillar 1 to Pillar 3 is mostly direct linked to the VTP program, where Pillar 1 also is talking about the early testing and optimized treatment for our infants, adolescents, and children that are exposed to HIV. So Pillar 1 talks to all the 95, the testing, the treatment, and the viral load suppression for children. Then Pillar 2 is talking to closing the treatment gap for pregnant and breastfeeding women living with HIV. So it's only talking to the first and second 95 because they should be on treatment also. Pillar 3 is talking to prevention of new infection. That's when we're talking to PrEP. for HIV infection among pregnant and breastfeeding women. So here we were talking about the prevention, the PrEP initiation for pregnant and breastfeeding women, also the interventions addressing that. And pillar 4 is addressing the rights, gender equality, and social and structural barriers. Here is mostly where we invite our other departments like social development and education to assist us on addressing these issues that may hinder our pregnant and breastfeeding women to access their services. So we address that. So I just wanted to make highlight that we remember always that Global Alliance is part of our interventions. Can you move to the next slide, please? Next slide. Okay, so here I wanted to say, because all along I was presenting about the HIV, so now I want to talk more or little about syphilis also, so that we understand where are we on the syphilis. And we have realized now recently that our syphilis prevalence is increasing, where it was at 2.6 in 2019, and currently we are above 4%. So also syphilis is going up. And our congenital cases now also they are rising from 373 in 2020, and now around 2023 there was 1.7. And remember, only these ones that are reported. Mostly we have challenge also not of reporting the congenital syphilis. So if we can improve reporting, it means it might be more than what we see now. And we know congenital syphilis also is the major cause of our stillbirth, neonatal death, and long-term disability, and which can be preventable. And our high-risk women usually are those who book with already infected with HIV and they book late. So when we identify them, it's already late. So we need also to promote early booking and testing of all these infections so that we eliminate both of them. And it has been shown that most of our co-infection, like the syphilis, the women with HIV, they are more at risk of getting the syphilis also. Can we move to the next slide? So why syphilis matters in pregnancy? Because we want to reduce the risk on the fetus or on the newborns, because as I said, the untreated maternal syphilis can be transmitted vertically during pregnancy and birth. So we want to screen it during pregnancy so that we prevent the risk of infection to their inborns, and we want to minimize the complications and avoid or prevent the stillbirth and prematurity. And we also need to make sure that we treat them early so that they don't continue infecting their infants, or the women should not have complications, because if they stay with infection without being treated, they will complicate also. Next slide. Because of time, I can just move. We can skip this one, just showing how to test them. We test HIV and syphilis at the same time. And this is the type of test that we use, the rapid, and we confirm with the RPR. Can move to the next slide. I will rush on now because the time. Okay, I think what is important also here is not to make sure that all our pregnant women and their children, we need to test them. We need to make sure that we manage them. So for babies, we check for their symptoms so that we know how to manage them, how to give them treatment. And even the mothers, we need to understand their treatment status so that we know how to manage their children. Can we move to the next slide? Okay, so this is just showing, it's on the guideline. On our VTP guideline, the algorithm, you can follow it, but it's showing the categories on how to treat the infants that are exposed to syphilis, if they have symptoms, if they don't have symptoms, or if their mother was not treated well. So you follow all this algorithm to know how to manage the exposed babies. Next slide. Next slide is still the same slide. Okay, also what is I wanted also to bring to your attention is the importance of notifying our congenital syphilis. So we must make sure if the mothers give birth to babies that have syphilis, we need to report it, and we need to report it within 7 days. So, and we test them. We can move to the next slide. I think this was only the treatment of their partners. Also, we can refer on the guidelines to showing us how are we going to treat the partners and with different symptoms or no symptoms. So the treatment or the approach will be different whether they have symptoms or not. So we can move to the next slide. Okay, so the last infection which we want to talk about is the hepatitis B. Also, just to make sure that we, in every pregnant woman that we see, when we tested HIV, we test syphilis, we also need to test for hepatitis B, because we're also seeing a lot of increase on the hepatitis B. We can move to the next slide because this is just an overview. Okay, so what is important also wanted to highlight is this, that why are we pushing or why are we advocating for hepatitis B to be screened and treated during pregnancy? Because now we have seen that perinatal transmission is associated with more than 90% risk of developing chronic hepatitis B, meaning if our infants, they're born with hepatitis B, the chances of them complicating is higher than when they get the hepatitis B at a later stage. So we need to prevent this so that our infant does not get the hepatitis B to prevent a lot of infections. You can move to the next slide. Okay, so as a country, we do have hepatitis B guideline also, which is also linked to aligned to VTP, but we do have it separately where it explains now how do we get the hepatitis B. We know part of, as we're talking to VTP, during delivery or during pregnancy, they can get hepatitis B. So we need to screen the pregnant women so that we minimize this, and we need to give them. Actually, we were giving them the vaccine when they test negative, but now it's being halted. But in a way, when they test positive, we can give them we can move to the next slide because what I'm talking to is on the next slide. When they test hepatitis B positive, we can give them the tenofovir. If they don't have the tenofovir, as a single dose, we can give the very same Truvada that we are giving for PrEP to prevent hepatitis B infection. And remember also, hepatitis B is a chronic, so meaning they are going to continue with these infections. So what is helping us here, whether the pregnant women test positive or negative for HIV, and they test positive for hepatitis B, the very same treatment is going to help us, because when they are HIV positive, they will get the TLD, which has tenofovir. So it will be helping them with hepatitis B and HIV. When they test HIV negative but hepatitis B positive, they get the Truvada. It also assisting them to prevent the HIV, but treating also the hepatitis B. So it will be helping us in a way. So if now their infants are, okay, for the infants that are born from HIV, from hepatitis B positive women, they are supposed to get the hepatitis B birth dose within 24 hours of birth. Then we continue giving them with the schedule of hepatitis B at 6, 10, and 14 weeks. And as I said, the vaccine now that was supposed to be given to hepatitis B negative women, now, so we are still working on that. The guideline is being approved, so we will share if anything changes. Can we move to the next slide? Oh, thank you. That was my end. And apologies for rushing. The time was not on my side. Thank you.
Thank you very much, Ms. Koza, for your insightful presentation. You basically just summarized the updated guideline for VTP. So we're going to move to our next speaker, which is Ms. Ika Chingwe. She'll be speaking to the characteristics and the 6 months viral load suppression of clients presenting with advanced HIV diseases in the restaurant. Thank you.
Good morning, colleagues. I'm Elizabeth Kachingwe. I'm a senior researcher at HERO, VITS Health Consortium, and today I'll be presenting the findings from our study entitled Characteristics and 6 months viral load suppression of clients presenting with advanced HIV disease in West Rand District. Yes, next slide, please. So as of 2024, approximately 7.8 million people were living with HIV in South Africa, and about 6 million were on ART. However, despite the progress in ART coverage, about 1/3 of clients continue to present with advanced HIV disease at the time of ART initiation. HD as defined by CD4 count. HD as defined by CD4 count of less than 200 cells per microliter, or WHO stage 3 or 4 condition. This persistent burden has been reported across multiple studies. As you can see on the bar chart on the left, Kitenge and Kamosa have reported that the same statistics. As you can see, the numbers are going down, but they're not substantially going down. Next slide, please. So clients initiating ART with advanced HIV disease face a significant clinical challenges. They are at an increased risk of severe infections, delayed ART initiation, and higher visit burden due to frequent clinical follow-up. Clinically, these individuals experience poor outcomes, including rapid viral load rebound, rapid declining of CD4 count if they interrupt treatment, but also increased mortality. Next slide, please. So the preferred study was conducted in West Rand District with the aim of describing the characteristics, service delivery preferences, care expectations, and 6 months treatment outcomes of client initiating ART. It was a prospective observational cohort study. We enrolled adults with HIV initiating ART or on their ART treatment within the first 6 months. Participants were recruited from 18 public healthcare facilities between June 2022 to September 2023. Data were drawn from structured interviews, facility records, electronic medical records such as NHLS, and also TIA.net. So just to mention that this study was conducted across 3 districts, including West Rand, but also in Nchazeni and in Mpumalanga, but also King Tetwayo in KZN. So today I'll concentrate on West Rand. Next slide, please. No, let's go back a bit. Sorry. Yes. So the primary exposure of this study was advanced HIV disease as defined by CD4 count in WHO staging. Baseline CD counts were measured from tests conducted within 6 months before ART initiation or 1 week after ART initiation. Our primary outcomes were retention in care, which was defined by attendance of all scheduled clinic visits or a documented transfer at the initiating facility. Viral load suppression at 6 months was defined as the tests that were conducted between 3 months and 9 months after ART initiation, because we understand that at this period the new guidelines were already rolled out, so 3 months viral load was already implemented in some of the facilities that we conducted the survey. We categorized viral load suppression as 50 as suppress 50 copies, less than 50 copies per mil, and low level viremia 50 to less than 1,000 copies per mil, and suppress 1,000 1,000 and above. Next slide, please. So comparing the demographics characteristics between clients with HD and those without HD, we observed several key differences. But just to take you back, that in West Rand, we enrolled 373 clients in the preferred study. Among those, 59 were excluded because they did not have a baseline or WHO staging documented in tier. And so we moved forward with the analysis with 313 clients who had CD4 or WHO staging. And among those, about 36% presented with advanced HIV disease. So as we can see on the table here, a majority of advanced HIV disease clients were older as compared to those without HT, but were also male. And I have presented the results of the other districts. The trend is the same for West Rand, also another district in King Tshetswayo and in Khazeng. And clients with advanced HIV disease, mostly, let's go to the next slide, please. Clients with advanced HIV disease mostly presented for HIV testing because of illness, not voluntary testing or referred by the clinician. There was also, we observed also a high prevalence of comorbid TB, which is not surprising because TB is a criteria for identifying advanced HIV disease. But also we observed a high uptake of TB screening among HD clients, but also testing at initiation. Let's move to the next slide, please. So retention, our 6 months, I'm going to take you through the preferences because during the survey we also asked the participants to give us like what are their preferences of service delivery. We see that there were very few preferences that were different between the two groups. So both groups, they wanted to attend clinic alone, unaccompanied. They preferred to receive their medication through external pickup points. They also preferred less frequent clinic visits. And we see that there was a slightly higher proportion of clients with HD who preferred to receive like more treatment information, but also they preferred more counseling than what they received on the day of initiation. And let's move to the next slide, please. And here I'm presenting our 6 months outcomes. We see that retention in care was not different between the two groups. And this trend was observed in all the districts that we conducted the survey. So retention was the similar between the groups, but I would like just to note that the loss to follow-up, like disengagement from care, was high between among both HD and non-HD clients, 21% among non-HD and about 19% among HD clients. But viral load suppression was different between the groups. The 6 months viral load suppression, we see that clients with HD were less likely to achieve viral load suppression at 6 months and were twice as likely to experience low-grade viremia. as compared to clients without HD at initiation. Let's move to the next slide, please. So our discussion, several key findings emerged from this analysis, as we have seen that HD clients had distinct clinical profiles, often presenting for care due to symptomatic illness as compared to non-HD clients, and also they experienced, the high proportion reported that they experienced treatment side effects after ART initiation. And comorbid TB was common among HD clients. As I've mentioned, that it is not surprising as on TB is a criteria for identifying advanced HIV disease. But what was encouraging is that we saw the high uptake of TB screening and TB testing among the HD group, which is showing high adherence to treatment, to guidelines. Despite this same-day ART initiation was also less frequent among HD clients, though by 1 week, or about 92% of HD clients had started treatment. At 6 months, as I've mentioned, that retention rates were comparable among the two groups. But viral load suppression was significantly lower among clients with advanced HIV disease. So with higher rates also of low-level viremia. So service delivery preferences were mostly similar between the groups, as I've mentioned, though those with advanced HIV disease had a strong desire for more counseling and also treatment information. So in summary, let's go to the next slide, please. In summary, clients initiating ART with advanced HIV disease are less likely to achieve undetectable viral load within 6 months of treatment, while service delivery expectations were largely similar between the groups, but the findings highlight the need for a closer examination of HD care practices. High disengagement rates across both groups point to systemic challenges in long-term retention, and we recommend that streamlined diagnostics and clinical processes should be streamlined and integrated to enable faster ART initiation and client-centered service delivery models to accommodate both the universal and HD clients' specific needs. Acknowledgements, please, the next slide. So let me acknowledge our funders for this study, the Gates and Melinda Foundation, but also our study teams, Return 6, HERO, National Department of Health, but also AMBIT teams. Thank you so much.
Thank you so much, Ms. Gachigwe. Can you please give her another round of applause? So, ladies and gentlemen, with her presentation, we see that we still have a lot of work to do in terms of the viral load suppression when 36% of our clients are still presenting with advanced HIV diseases. So we still have a lot of work to do. Thank you so much. I am going to introduce our next speaker, which is Dr. D. Tlhabela. Dr. D will be speaking to factors influencing the implementation of termination of pregnancy policy in Gauteng Department of Health. Thank you.
morning, colleagues. Today I'm going to give you the results of my study with the title Factors Influencing the Implementation of Termination of Pregnancy Policy in the Gauteng Department of Health, a multi-study method. I'm not going to go through the outline. The study was a multi-study method where there was I'm so nervous now. It was the, oh gosh, I forgot now. It was systemic review and also quantitative data collection, and the last one was qualitative data collection. So I'm only going to give you the results of the qualitative data collection, which was done amongst doctors who are offering second trimester termination of pregnancy, and also the termination of pregnancy providers. So the study was conducted in the whole of Gauteng, the 5 districts. It was done in the community health centers where termination of pregnancy is provided, and also in the hospitals where termination of pregnancy is provided. Just to give you an overview, in Gauteng, with the 26, so if I'm not mistaken, hospitals that are offering termination of pregnancy, only 6 are offering second trimester termination of pregnancy. And then some of the facilities that are supposed to offer termination of pregnancy, they're not doing so. So I just want to go to the introduction. Unsafe abortion remains significant cause of maternal morbidity and mortality globally. Despite the emphasis on women's reproductive rights and the availability of TOP policy, thousands of pregnant women, girls in the developing world still opt for clandestine or self-induced abortion method. Reasons could include poor socioeconomic circumstances, a failing public health system, lack of implementation of legislation, lack of political will, and or poor knowledge. I have just highlighted that there is a failing public health need where I've mentioned that some of the hospitals are not offering termination of pregnancy as required by the Choice of Termination of Pregnancy Act number 92 of 1996 as amended by Act number 1 of 2008. Despite the reforms and the promulgation of the abortion law almost 2 decades ago, unsafe abortion, please, next slide please. Remains an integral factor leading to maternal mortality and morbidity in South Africa. TEFU and RESPEL 2017 found that trained TOP providers often experience feelings of anxiety because they fear acts of discrimination and or violence. There is a need to improve the implementation of the TOP policy to improve access to the services and recruit additional TOP providers. Next slide, please. And then the research question was, how can the TOP services in the Gauteng Department of Health be better aligned with the TOP guidelines of the National Department of Health in accordance with the Choice on Termination of Pregnancy Act number 92 of 1996 as amended by SITOPA Act 2008 number 1. And then we had only 4 objectives. Objective 1 was to review international literature on factors affecting implementation of the policy. And objective 2 was to explore and describe the TOP providers' perceptions impacting on the successful provision of TOP services in Gauteng. Objective 3 was to explore and describe the managers' and doctors' perceptions impacting on the successful provision of TOP in Gauteng. And objective 4 was to audit the demand for and resources available in the Gauteng Department of Health for the provision of TOP. And then we are going to discuss the results of objective 4 in other forums. That's why I said the results will be presented separately. Now I'm only going to give you the results of both objective 2 and objective 3. for both the TOP providers and also the doctors and managers of the TOP providers who provide TOP in Gauteng. Next slide, please. The population and sampling. For qualitative phase of the study, population included all trained nurses and midwives working in GDOH, as well as all managers and doctors working in clinics and hospitals where TOP services are provided in GDOH. Sample: one purposely selected TOP nurse midwife at the 14 community health centers that provide TOP and 6 hospitals that offer first and second trimester termination of pregnancy, which was N was equal to 20. One purposely selected manager and doctor for each of the 5 districts in the GDOH in each of the 6 hospitals. And then for quantitative phase of the study, 7 CHCs and 1 PHC and 6 hospitals offering TOP. So remember, I'm not going to give you the results of the quantitative data. It's going to be done in other platforms. Then we had trustworthiness and ethical consideration. The rigor of the study was ensured and the qualitative phase followed the principles of credibility, confirmability, dependability, and transferability. The audit tools for the quantitative phase where GDOH checklist attempts were made to ensure accuracy and consistency when entering the data, and input errors were checked and corrected prior to analysis of the data. Ethical approvals was obtained from the University of the Witwatersrand Human Research Committee and then the GDOH Research Committee. The principles of respect for persons, beneficence, non-maleficence, and justice were adhered to. The challenges for providing TOP. The data collection was done as a face-to-face interview for each participant, whether it was the TOP providers or the managers or the doctors, because now one wanted to make them feel free to be able to tell all so that they must not be intimidated by others. So a lot of them, actually all of them, alluded to shortage of trained providers. Where data collection was done, we found that the TOP providers in those facilities or clinics were working alone, like one nurse doing administrative work and also doing termination of pregnancy. There were only 2 facilities where there were 2 providers at a given time. And then when I'm not on duty, this is one of the providers saying that when I'm not on duty, maybe I'm sick on that day, my patients are not attended in the clinic. So it is better if maybe there are 2 providers so that if the other one is not on duty, the service is continuing. But if we are alone, working alone, then there's no one who's going to see the patient when the other one is not in. So as I've mentioned, it was not said by one provider, but a lot of them said the same thing in different wording. Shortage of essential equipment such as MVA, manual vacuum aspiration packs, cannulas, and vaginal speculums, as well as supplies like linens and sanitary towels, and the supply of medication for TOP is intermittent, particularly mifepristone. And then one of the providers said, but they will tell you that cannulas are expensive. So really and truly, how are you going to perform if you don't have enough aspirators, enough cannulas? And unfortunately, that's a challenge that I'm facing. So the providers are saying that they don't have enough cannulas, and sometimes they use biocide D for sterilization, which predisposes or compromises the patients in as far as infection prevention is concerned. One provider said that, okay, the equipment like the sonar machine, okay, we do need a sonar machine because some of the patients you cannot palpate. Management support, this was very interesting because when I interviewed the managers, participants work alone without the support of their colleagues, which makes work stressful. One of the managers had to say, no, I don't. They don't, no, this is what the participant, no, I don't. When she was asked that, do you have management support? They don't support us, they just complain. We see them only if there is a complaint from other patients. Are you saying something? They don't do that. We just see them when there is a problem only. And then this was confirmed by one of the managers in one of the hospitals. She actually giggled when I asked her whether they were giving support to the TOP providers or not. And then she giggled and said, no, she doesn't give them support. And then another manager in one of the hospitals, she said that she doesn't give support. She was only aware when one of the providers resigned, and then during the exit interview, she mentioned that she didn't have support of the manager, and that is the only time that she knew that she was not supporting them. She cited issues of religious belief as a manager to support the TOP providers. And then work environment. Stigma is still prevailing in TOP. Providers feel stigmatized for the work they were doing, indicating that others held negative and often unfair beliefs about them. One provider has to say, some people sometimes judge us like they think that we are killing. That is not nice to hear from your staff or from your managers. And then one said stress. Sometimes when you talk to the patient, it's so stressing. Like, for instance, if you come across with a rape case, it's so affecting me as an individual. I know how this can happen to this woman. One of the providers in one of the hospitals, this I still remember vividly. She said to me that she was even afraid to go to the canteen because her colleagues are calling her in the ward and said, how many have you killed? And then she was like, she doesn't want to go out. She always remains in the ward. Work environment continued, lack of space and overcrowding in top units, which compromises patients' privacy. A single room was often used for multiple purposes, pre- and post-procedure counseling, ultrasound scan, and the top procedure itself. This lack of dedicated space was a recurring concern in amongst the participants. So in all the hospitals that are offering second trimester, the one hospital that has got many, if I can say, dedicated beds for TOP is one academic hospital which only has got 4 beds. The others are having 2 beds or 1 bed, and then they have to do everything in that particular room. And the space, also the space is not enough for my patient. Like, for instance, I'm having, when I'm done the group counseling, we don't have enough space for here. In one of the hospitals, the patient was sitting on the passage outside, and everybody could see that they're coming to do a termination of pregnancy. And in other facilities, the very patients that are terminating are also mixed with the antenatal patients. Factors impacting on the implementation of the policy: access to second trimester TOP. This is a very, very serious issue. As I've mentioned, that only 6 out of the 26 hospitals where maternity are offering second trimester. This participant has this to say. This doctor actually is a doctor with this one. We found that the demand for first trimester has actually doubled over the other years. So it comes like it kills the implementation of the second trimester, because now we found that we are swimming against the tide. Let's outsource, but the numbers are too high that we can't even start anew easily because the demand is actually high and the population has grown significantly. And then, because of lack of facilities like the second trimester, patients are forced to go for backstreet abortion, because in one of the clinics, the sister there, this was one of the busiest clinics that offers termination of pregnancy, and then they said they're overwhelmed that they didn't even know where to refer the woman with second trimester. You can just imagine if the hospital is only having 2 dedicated beds for TOP second trimester, and then the others have to go to wait, and then because they don't want this pregnancy, they end up saying, no, I just want to have this done with, and then they go back street. This doctor has this to say: they exercise their right to go to the GPs and they go to backstreet. And this is seen by the high number of emergency hysterectomies we do for sepsis, that is when we see that this is a challenge. I think we had 3 or 4 maternal deaths a month that were causes of the complication of sepsis or illegal terminations. They contribute to a lot of mortality. Last year, there were 5 out of 20 maternal deaths as a result of termination of pregnancy. And then there are opposition to TOP. The providers, the doctors, they mention conscientious objection. Yes, the TOP providers or the doctors are likely to opt to conscientiously object. This termination TOP provider has to say, I don't think it's something that could be resolved easily because it all starts from beliefs. Maybe we believe in TOP, but it's something that other people still take as taboo. So, in religion, we can't force or change them to believe in what you believe in. Though we all know we should leave these beliefs behind, but I feel like it's still difficult for some people to be able to do that, to be able to cut the line between the religious and work. I'm sorry, I forgot to say next slide. I don't know. Oh, next slide, please. Managers and doctors' results. Managers and doctors agreed with the issues raised by the TOP providers. You could even feel that they heard what the TOP providers were saying because they were also echoing what was said by the TOP providers. And then recommendations for services. A dedicated, possibly prefab space to be made available to enhance privacy and of the patients. Virtual consultation where the provider will take the history of the patient and then advise the patient about accessing the facility. Considering allowing providers to work outside normal clinic hours and be given time back in lieu. And then values clarification workshops to be conducted to address issues of conscientious objection. Recommendations continued. TOP training be included in the curriculum of the medical and nursing students, pharmacists to prioritize ordering of mifepristone, and then managers should attend workshops on collegial support and management of TOP services. Mentoring program should be made available to TOP providers, and TOP providers should be given regular opportunities to attend peer support and debriefing sessions. And then limitations of the study. The sample size did not include all facilities due to not receiving permissions and collected only over 3 months period. Data availability restricted to information contained in register. This data is only for the quantitative one, so you can ignore for now. And then there was some confusion in the register regarding patients' parity versus gravity. This was noted in the quantitative data, not the qualitative data. Number of facilities offering second trimester TOP to be increased. Patients will be made aware that they need to go for first trimester abortion to the clinics and only referred to hospitals for second trimester. Robust family planning education to patients to reduce repeat TOP. I now remember that family planning was saying is contraceptive and fertility planning. So I forgot about it when I was writing this presentation. Providers to attend to patients the same day as the request. Training on ultrasound to reduce the number of inconclusive scans, because there were about 4 or 5 providers where all their scans, they were saying they are inconclusive. So you could see or feel that maybe they don't have a clue as to what and how to interpret the scan, because you can have almost 20 or so of your scans being inconclusive. Municipal bylaws regarding the illegal abortion advertisement to be enforced. And then conclusion. The study yielded achievements of the objectives as intended in this research project and constrained working environment and negative attitudes in the community and amongst health professionals negatively influenced the implementation of the TOP policy. Based on the recommendation of this study, It is hoped that measures will be put in place to improve access to TOP policy, implementation of the policy. And I thank you, and I would like to also thank the Gauteng Department of Health for sponsoring my study at the University of Witwatersrand. Thank you very much.
Thank you so much, Doctor, for your insightful presentation. Ladies and gentlemen, can you please stand while we give Dr. Tlhabela a standing ovation? She just recently qualified and graduated for PhD. You can walk down. All right, thank you again, ladies and gentlemen. Moving forward, I am going to introduce the next speaker, which is Gauteng Department of Health Legal Unit. They'll be speaking to medical legal litigations in obstetrics and pediatrics. Thank you. Ladies and gentlemen, it looks like the legal unit is not here. We're going to move to Ms. Z. Shabangu, and she'll be speaking to infant mental health.
Good morning, colleagues. I was expecting everyone to stand up and dance to that song. Thank you, and first and foremost, happy Mental Health Day. Thank you for being given this platform to share on a topic that is very close to my heart. Besides working at VUT, I'm also in private practice, where I do most of the work on infant mental health. Because maybe people will be asking, why are you talking about infant mental health when you are at a higher institution? So that's where my passion for the work comes from. All right. As they've mentioned, my name is Zandile Shabangu, and I'm an educational psychologist. I work full-time at VUT, as mentioned, and have been running a private practice part-time for a while. So today, be sharing, I think you know most of the information. So I'll just be adding to what you already know on infant mental health. I'll try to remember to multitask. Okay, so there, that's just a highlight of what I'll be discussing. Firstly, I will look at infant mental health, the definition of what it is, and key influences in infant mental health, signs of a mentally healthy infant, and also discuss a bit on how caregivers can support infant mental health, and how health professionals, which is all of us in this room, how we can support infant mental health. And last but not least, I'm going to share some perspectives on Jenny Peckel, who I have partnered in doing this work on infant mental health. She was supposed to be the one presenting, but due to unforeseen circumstances, because she's based in Cape Town, so she requested that I step into her space. So I'll be sharing on her perspective. Thank you, colleagues. I'll try to be quick so that we are in time for tea. Right. There we go. Okay. Infant mental health, what is it all about? It refers to the social, emotional, and cognitive well-being of babies from birth until around they are 3 years old, and the quality of their earliest relationships. It also looks at how infants experience, express, and regulate emotions, and how they form close relationships and begin to explore and learn about the world. Why is it important? It's important because early experiences literally build the brain. It secures responsive caregiving, creates neural pathways that support resilience, empathy, and learning. Adverse experiences can affect attachment and increase the risk of later development of mental health difficulties. So colleagues, it's very important that we also take this one seriously. As much as we take care of the mother's mental health, it's also important that we also teach them that even while they're pregnant, whatever they go through, the child can have negative consequences from that. They can be born with already presenting mental health issues. Okay. Next slide is talking about the key influences in mental health, in infant mental health. What's important is caregiver sensitivity and responsiveness. So how the mother comforts the baby, responds to their cries, plays with the baby, and shows affection, it affects the baby's mental health. Secondly, parental mental health also plays a critical role in how the baby's mental health is formed. If the mother or the caregiver is stressed, is going through depression, has anxiety, and other mental health issues, it affects the baby's sense of security. Therefore, possibly ending up developing insecure attachment. And that comes with its own mental health issues as they grow up, right? Also, family and social environment also has a huge impact on the infant's mental health. If mother or caregivers come from a situation of poverty, where there is violence, where support systems are not in place, and other cultural practices that are not going to be supportive for the mother raising the baby. It can also affect the baby negatively. And lastly, on this slide, infant temperament, that is the baby's mood. Some babies are naturally more sensitive, while others are more adaptable. So that's it. Then the next thing that we'll look at is signs of a mentally healthy infant. Firstly, the baby looks for comfort and responds to the caregiver. Secondly, the baby is able to settle after the mother soothes them. So if maybe the mother tries to soothe the baby and they still continue to cry or be irritable, that's also another indication that maybe the child is struggling with something else. Or maybe there's not a good connection between the caregiver and the baby. So mother needs to go and seek psychological intervention and guidance, like parent guidance, which is what we do also as psychologists. If the baby shows curiosity and interest in their surroundings, that's a positive sign. If the baby begins to form predictable patterns in sleep, feeding, and mood with the caregiver and how they support them, that's a positive sign. And then just a note at the bottom, infant mental health is the foundation for later emotional, social, and cognitive development. When caregivers are supported to respond sensitively and consistently, babies learn that the world is safe, setting them up for resilience and healthy relationships throughout life. So we are responsible for making sure that babies have a solid foundation for a healthy future in terms of mental health. How caregivers can support infant mental health. Firstly, they need to build a secure attachment. That is by responding warmly and consistently to the baby's needs. So if mommy or daddy responds in an erratic manner, that can confuse the baby because they're not sure what to expect. Caregivers need to promote positive interactions with the babies. You need to play, talk, have eye contact with the baby, singing, and also ensuring that you give them gentle touches. Just to share a side thing, I was consulting with Jenny Peckel, and she mentioned that, I don't know if it was a study or she made her own inferences, that she encourages pregnant mothers to start connecting with the baby while the baby is still inside the tummy. Because once they come out, they already know your voice and they can feel that warmth that you have towards them. And the opposite is also the same. If the baby feels rejected from the womb, when they are born and they grow up, we find that they present with rejection issues, especially if mothers maybe were second guessing if they should terminate or not. Unfortunately, the babies store that in the cellular memory. And later on you wonder, why is this child feeling rejected? That is when you do the intake history and you talk to the parents, you find out at some point the parent wanted to terminate. So already when the child is attached to you, they pick up your emotions and your energy and they grow up with them. So that was a side note, colleagues. It's important that parents also receive support in terms of addressing postnatal depression. They offer prenatal and postnatal classes, psychoeducating on infant mental health, anxiety, or stress. That they create safe, predictable environments. Then they also offer early interventions when risks are identified. The next discussion will be on how health professionals can support infant mental health. Number one, at every contact, make sure that you observe infant caregiver interaction, how the mother interacts in terms of soothing, playing with the baby, and also are they having eye contact with the child. Secondly, on that point, ask gentle questions about parental stress, mood, and support. Because what I've noticed is that mothers are very sensitive if you start questioning them in a manner that they don't understand. They might also tend to think that maybe you are criticizing their parenting skills. So gently ask them, how are you doing? Are you adjusting well to the baby? And lastly, on that point, reinforce positive caregiver behaviors. So if you notice something positive that the mother is doing, don't keep quiet. Reinforce it and maybe compliment them that, look, you're doing this very well. Please keep it up, just to encourage that positive interaction with the baby. Secondly, screen and identify developmental milestones, which I'm sure that's what you're already doing. Signs of bonding difficulties. If you pick up something that doesn't sit well with you on how the mother is bonding with the baby, that one needs to be followed up. Risk factors that can affect that bonding space. I've already mentioned parental depression, trauma, substance use, anything that has to do with family violence. Then the last point on the slide is support parents. Normalize challenges of caring for a baby. So mothers should not be afraid to indicate that, look, I'm struggling. Do you have any ideas on what I can do to parent my child better or my baby, to do something better for my baby? So have that open platform. Secondly, to this point, encourage responsive caregiving, such as holding, talking, playing, and soothing. And the last point is share simple routines that build security between mother and baby. Feeding, sleep, touch, and play, they should know that these are okay to do with the baby. Number 4, still continuing on how health professional can support. 4, address parental well-being. Screen for postnatal depression or anxiety or any other mental issue that you might be suspecting. Or if you're not sure what it is, then I would encourage that you refer to a psychologist to try and assess where the problem is. Provide a reassurance and resources for the mother. Refer for counseling, mental health, or social services if needed. And number 5, promote connection. Encourage daily serve and return interactions with the baby. A lot of eye contact, smiles, copying sounds, and gestures with the baby. And remind the caregiver that every warm response builds your baby's brain. When to refer: persistent feeding or sleeping difficulties, baby withdrawn or unresponsive when you try to interact with them, high parental distress if you notice that, and if you feel that mother and baby are in an unsafe environment, concerns about neglect, trauma, or developmental delay. Remember, you're not only treating physical health, you're also shaping lifelong mental well-being. Infant mental health, now I'm going to share a bit on Jenny Perkel's perspective on infant mental health. So who is this Jenny Perkel that I'm talking about? She's a clinical psychologist based in Cape Town, South Africa, practicing since 1996. She specializes in infant, child, and adolescent mental health. She offers parent guidance and therapy, perinatal counseling, etc. Recently, I saw that on her website, she has opened an online support group for pregnant and mothers who have recently given birth. So she has that support group available online. She's an author of 2 books, Babies in Mind, which is Understanding Your Baby's Psychological Needs, and Children in Mind, which talks about their mental health in today's world and what we can do to help them. Her theoretical orientation is integrative, drawing heavily on psychodynamic object relations perspectives, but also using evidence-based work from neurobiology, epidemiology, genetics, mindfulness, CBT, DBT, where relevant. I've just put a summary on key themes in her infant mental health approach. She says infants' psychological needs or mind of the baby emphasizes on understanding what the infant might be experiencing internally, not just their observable behavior. She says parents or caregivers need to listen to cries, observing, trying to make sense of the meaning behind them. Every cry, I'm sure as health professionals, you know, means something. So the mother needs to be aware of that. Recognizing the infancy period as one with intense dependency, high vulnerability, but also hugely formative. Early relationships, parental responsiveness, emotional availability matter enormously. Recognizing, mental health role of caregivers, parental emotional state has a large influence on infant mental health. The parent's ability to be emotionally present, to regulate themselves also, to respond to infant cues is very important in infant mental health. Reflective parenting or guiding parents to reflect on their own experiences, their internal states, how these may shape their responses to the infant is encouraged. Because you'll find that maybe parents have had negative childhood experiences. If they haven't resolved that, that will affect their parenting and also how they relate to the child sometimes, causing a lot of damage. So it's important that we encourage parents to reflect on what they've been through and how it will affect them as parents. Weaning separation processes. PECL treats weaning from breastfeeding or the bottle, sleep independence, transitions, caregiving separations as psychological events, not just physical or behavioral. They are part of the infant's gradual differentiation from primary caregiver and can involve loss, anxiety, and identity shifts. So they need to be done in a very careful and sensitive way so as not to cause any mental health issues. How caregivers manage these transitions deeply impacts the infant's sense of safety, attachment, and autonomy. Preventative focus and early intervention is also important. She advocates for early support, postnatal, perinatal infancy, rather than waiting for severe symptoms. Prevention of mental illness in infants is tightly linked to support for parents, emotional attunement, and secure attachment. Babies in Mind workshops, parent guidance, psychoeducation are key components. So she doesn't only talk about infant mental health, but she has created Babies in Mind workshops that are presented by different psychologists all over South Africa, and I'm one of the presenters. So if you are interested in knowing more about the Babies in Mind workshops that are presented to pregnant mothers, you can go to the website. I'll share the details later on towards the end. Maybe add that to prenatal classes for the pregnant mothers. She provides open access workshop materials for Babies in Mind. A sensitive response to environment and socio-economic issues, awareness that many infants and families live under stress, poverty, trauma, etc. These contextual factors shape infant mental health and can increase the risk of them developing mental health issues. Her approach integrates research from neurobiology, epidemiology, and also local South African conditions to understand how adversity affects infants. Non-judgmental, holistic, person-centered, reflective approach where the emphasis is that there are no one-size-fits-all solutions. Parent experiences, cultural norms, individual infant temperament all matter. And lastly, the clinician's role includes helping parents think about their own history, fears, expectations, and how these inform their interactions with the baby. I think I've already mentioned that point prior. Strengths and implications for practice. She indicates from her work that the aspects need to be considered, which you might incorporate or think through in your own assessment and interventions. Firstly, it's early screening, not just infant behavior, such as sleeping, feeding, and crying, but also parental distress, postnatal depression and anxiety, parent-infant relationship work, promote secure attachment, responsiveness, use reflective practices with parents, and then engage or help the parents practice transitional or weaning periods as key windows for intervention. Sleep changes, feeding changes, first separation, etc., if handled poorly, can leave lasting emotional ripples. Cultural sensitivity is important. Recognize local norms around caregiving, breast versus bottle feeding, family environment or involvement, child minding, etc. What is appropriate? Responsiveness depends on context and also cultural background, because we need to understand we come from different cultures and maybe we do things differently. Then preventative public health workshop models. Because PECO makes much of prevention, psychoeducation workshops, you might think in terms of scalable programs, not only one-on-one. Integrative approach, be willing to draw from psychodynamic, neurobiological, behavioral, mindfulness, etc., depending on what the infant and family needs. Limitations, psychodynamic relational lens is rich, but sometimes harder to operationalize in short assessments or interventions, and may lead to specialized training to apply well. Sorry, I've left you behind. In constrained resource settings, working intensively with parent mental states, histories, etc., may be challenging due to time, cost, availability of trained clinicians. Cultural beliefs, social stigma, variation in caregiving norms might both support and clash with some of the idle practices. For example, separation and infant autonomy. Just a side note, loving, responsive relationships are the foundation for lifelong mental health. And then those are the books that Ms. Peckel has written, and the last picture, that's the information and the website of where you can find the different psychologists around South Africa that offer the workshops that I was talking about for expectant mothers and maybe those who have recently given birth. And just to wrap it up, I found a cute quote while I was preparing. It says, "A child's mental health is just as important as their physical health and deserves the same quality of support." Thank you for listening, colleagues.
Thank you so much, Ms. Chabangu. That was for me personally, that was mind-blowing. I think each and every parent sitting here, we did a self-introspection, right? To assess our parenting skills and how we are navigating parenthood. Thank you so much. That will be the end from myself. I will be handing back over to Yolandi. Thank you so much, colleagues.
All right, thank you very much, ladies and gentlemen. It was very, very interesting first session. Quite somber, though. It brings all of our lives back into perspective, especially on Mental Health Day. Ladies and gentlemen, I want to thank Ms. Levitzo for the work well done, for facilitating the first session and trying to keep us on time. She will be back again during the last session. Ladies and gentlemen, tea will be served now. Please be seated while our VIPs get the first opportunity to go out. The ushers will show you where to go. Tea will be 20 minutes. So ladies and gentlemen, may we please request that we be mindful and respectful of the person behind you and only take 2 scones, please. So please be seated while our VIPs goes first, and then the task
Shapendias. Hallelujah! Hallelujah! Give me a J! Give me E! Give me S! Give me U! Give me another S! Hallelujah! Welcome back, colleagues, from your tea break. Let me take this moment and opportunity to thank our chairperson, Ms. Yolandi. Thank you so much for giving me the opportunity to come and stand right in front of everyone here. It is not by might, it is not by power, but it is by the pure grace of God. Amen. Yes, my name is Lorato Wahananyani. Just to correct the spelling on the program, I am Lo, not Lee. I'm from the Ekurhuleni Health District. I'm a midwife. Thank you so much. I just wanted to say, can we all make a Holy Ghost crazy noise in this place? As we clap our hands, yes. Thank you, thank you, thank you, thank you, thank you. Yeah. Let me take this moment now to acknowledge God who has carried us from day one until to the stage where we are. Had it not been for the Lord, a lot could have happened, but He sustained us, carried us, and we are here, and we can never manage not to recognize and acknowledge that it was the grace of God. Amen. Yes, because the beginning of wisdom, or rather the fear of God, is the beginning of wisdom. And we really were fortunate and blessed enough to be part of this conference from day one. We have witnessed, colleagues, the wisdom of God in everyone who has been privileged to stand on this podium. Every presentation, we saw God. Hallelujah. Without any further waste of time, colleagues, we are going to invite on the podium Dr. T.N. Majola, who's going to take us through the study results of immunization coverages barriers. Can we give her a round of applause?
Okay. Greetings, colleagues, with all protocol observed. My name is Tobelan Nompilo Majola, and I am a researcher from the Health Systems Trust, which is based in KwaZulu-Natal province. It is an honor and a privilege to be presenting today. So today I will be presenting on a study that was conducted to identify the barriers to childhood immunization, specifically under 1-year childhood immunization. So the study was conducted amongst 4 metropolitan municipalities. 1 was in the KwaZulu-Natal province and 3 were in the Gauteng province. And the 3 metropolitan municipalities were the city of Johannesburg, city of Ekurhuleni, and Tshwane. So today specifically, sorry? I'm Zulu, I'm sorry. Okay, so just to provide a brief background, as we may be aware, childhood immunization is the most cost-effective public health intervention, which is crucial for the reduction of morbidity and mortality. So in South Africa, we do have the expanded program on immunization, which was launched with an aim to protect children and pregnant women from vaccine-preventable diseases. However, despite the significant progress of the expanded program, the country has struggled with various outbreaks, specifically related to vaccine-preventable diseases such as your measles. I'll make an example of the recent outbreak in the Gauteng province of the measles, which goes to show that the issue of vaccination uptake is quite a challenge across the country. Estimates do suggest that there are just above 270,000 of children that are zero dose in South Africa. That is of the year 2024. And South Africa is regarded as one of the urbanized country, which relates to the rationale of basically selecting the metros and the urban setting within those metros. So therefore, it was then critical to identify the barriers and strategies to improve immunization uptake across the selected metros. So in terms of the objective that guided the study, we were guided by 3 objectives. The first being to identify the social demographic of zero-dose children, to assess the barriers affecting for an uptake of routine immunization services, and thirdly, to determine the factors in the routine of immunization services that affect the uptake of services by the eligible population. And then in terms of the methodology that guided the study, this was a mixed method study, which means we incorporated both qualitative and quantitative research methods. In terms of the qualitative component of the study, we conducted key informant interviews as well as focus groups, and the quantitative component entailed the administration of a survey with healthcare workers within the selected metros. And then moving on to the study setting, as I had indicated, the focus of this presentation would only be on the metros that are within the Gauteng province. So these were the 3 facilities that were selected in each metro. So the selection, firstly, of the metros were done by UNICEF, of course, in consultation with the National Department of Health. And the selection of the facilities within the metros were conducted in consultation with your districts and operational managers within the province. So moving on to the results. So we began by reviewing data from the district health information system to sort of like determine the trends of the zero-dose children from the year 2020 to the year 2024. So as you can see, I'll just make an example of the city of Johannesburg. There has been a steady increase of the rates of zero-dose children throughout the years. And a part of this increase can be attributed to the COVID-19 because after the introduction of the COVID-19 vaccines, some of the parents were reluctant to immunize their children, and that affected the childhood immunization. And then moving on to the main barriers, starting with the city of Johannesburg. So the first barrier that we identified pertained to parental or caregiver lack of knowledge. So what we had identified during the interviews and focus group discussion was that parents were aware that there are vaccines, but they did not understand the significance or the importance of vaccines. Some of them would say, we go to the clinic for routine immunization, but we don't understand a difference between a child who's immunized and a child who's not. So that was a challenge where some of the parents ended up not honoring their immunization appointments because they did not understand its significance. The second barrier was related to the issue of lack of trust in vaccine safety, which was basically stemming from the issue of misconceptions and misinformation from social media platforms. We know that in our day, social media really affects us, and like we take and believe in what is on the social media platform. So that also contributes to the lack of trust in vaccine safety and efficacy. Moving on to the lack of trust in the government and healthcare workers, that was also identified as a factor that contributed to vaccine hesitancy. The language barrier was also identified where because we had interviewed some of the migrants, they indicated that the language barrier between themselves and the healthcare workers contributed to them being reluctant to immunize their children. We also identified issues around financial challenges where some of the caregivers and parents indicated that it was a financial constraint for them to travel from home to the facilities, considering that some of the facilities are located afar from home. We also identified negative healthcare worker attitude as well as long queues, which basically demotivated some of the parents and caregivers from taking their children for immunization services. As I had indicated that we also administered a questionnaire with healthcare workers. These were some of the top 5 barriers within the city of Johannesburg, and these related to parental lack of knowledge, their education, their beliefs, religious beliefs as well was also identified in the metro. So moving on to the second metro, which is the city of Eguhuruleni. So similarly to the city of Johannesburg, consistent barriers were identified in the city of Eguhuruleni. However, we're also seeing that religious beliefs were now coming from the actual participants and not from the healthcare workers in this specific metro. And then moving on to the quantitative results, they are also consistent and they substantiate the qualitative results. However, in this specific metro, we also identified the issue of substance abuse, where some of the healthcare workers, specifically community health workers, indicated that they would visit home where there are children who are under-immunized, and they would find that most of the parents are substance abusing. Therefore, that contributed to them not honoring their appointments for childhood immunization. And then the final metro is the city of Tshwane. So, Tshwane. So, similar to the other barriers in the other 2 metros, some of the barriers were also consistent in this metro. However, what we identified that was unique for this specific metro was the issue of vaccine stock out. So some of the parents indicated that they would visit the facility and find that the vaccine is out of stock. So that contributed to some of the children being under-immunized. And then the quantitative results that supported this included the experience of care, parental and caregiver beliefs, parental or caregiver education, and religious beliefs. And what was unique in this specific metro was the issue of traditional health practices, where some of the healthcare workers in the survey indicated that some parents preferred traditional health practices instead of Western medicine, and that contributed to their hesitancy to childhood immunization. So just to summarize the main barriers across all the metros, the first was the lack of knowledge amongst the parents and caregivers, lack of trust in vaccine safety, religious beliefs, lack of trust in the government and healthcare workers, as well as foreign nationals' attitude and beliefs. And then some of the health systems barriers that we had identified included issues around the distance to the facility, long waiting times and queues, negative healthcare worker attitude, as well as vaccine stockouts and availability. So we do have some recommendations that we have proposed. The first being the promotion of health education. The fact that parents are aware of vaccine but they do not understand the significance goes to show that there's a lack of knowledge and understanding. So the first is to ensure that we promote education, we ensure that they understand why children need to be immunized. What is the difference between a child who's being immunized and a child who's not being immunized? The second one is to update and improve facility-based parental educational programs. So we are aware that clinics do have like the posters that explains the different vaccines, but it would be better if those posters are maybe in a local language that is, it's more easier for the caregivers and parents to basically understand what are those vaccines, when they should be taken, and what is the significance of those vaccines. The regulation of online information is quite crucial considering the misinformation and misconceptions around social media platforms. Collaborating with community stakeholders such as your ward councillors, your religious leaders, traditional leaders, because we're seeing that people within the community trust their leaders. So if we can sort of like use an approach where we use the leaders to also extend on the importance of childhood immunization, maybe we might also be able to reach those zero children within communities. Expanding the community-based outreach programs. We are aware that there are community-based outreach programs within the province. However, expansion is very important to ensure that we reach specifically the zero-dose children. Because to be quite honest, this study, the route that we took with this study was to look for participants within the clinics. However, we are aware that there are those participants that are within the communities and that are not taking the children to the facilities. So it would be important to try and target those that are at home to ensure that they immunize their children. Maybe sort of like have a program where they can catch up with childhood immunization. And then at the health systems level, we are proposing the improvements of staff conduct and primary healthcare supervision, considering that there were cases of some of the parents and caregivers who stated that they had experienced negative healthcare worker attitude. So it will be important to improve staff conduct and ensure supervision. Also, the second recommendation under the health systems level would be to ensure that vaccines are available and ensure supply chain resilience at all costs. Check the vaccine, order the vaccine on time. If there's a way of checking the potential or estimated number of participants or children who may visit the facility, try and do so and ensure that we have enough vaccines for the children that are meant to come during that specific week for childhood immunization. Improve on mobile health initiatives such as your SMSs and Mom Connect to sort of like remind parents of their appointment dates. Develop an electronic database to track childhood vaccinations. So what we noticed was that in some of the facilities that we visited, they still use paper-based, and that gets lost easily. So if we were to implement or develop an electronic database where we can track children and try and follow up to those who have missed any of the vaccinations. Documenting good practices is also very important because as much as the study sought to identify the barriers, we also identified facilitators. So some of the parents were indicating that they have very good healthcare workers whom they seek or they depend for health-related advice. So those were identified as some of the good practices within facilities. So if we were to identify those good practices and ensure that we sort of like try and expand them so that they can be adapted in other contexts to improve immunization uptake. And lastly, to strengthen relationships between the private and the public healthcare providers is very essential. For example, with regards to issues of data, we know that data for the public sector is like represented separately from the private sector. So it would be important that we integrate both data just so it's accurate data that is representative of all the population of South Africa or of the Gauteng province to be more specific. And then we would like to acknowledge UNICEF because this study was funded by UNICEF. We are also thankful to the Gauteng Department of Health, the district managers, the operational managers. They were very open and very supportive to the study. We are also thankful to the participants within the province who are willing to share their experiences, their perception regarding to childhood immunization. So this is the end of the presentation. I hope that you found it to be informative. Thank you.
Thank you so much to our beautiful doctor here, Dr. Majola, for your beautiful presentation and sharing all your findings and recommendations following your study on immunization coverages. I think as colleagues, we have a duty to do what is within our reach. When we go back to our facilities, when we go back to our different districts, to make sure that we improve on our conduct. I think that one, we don't need a budget for it. We can really improve how we communicate with our mothers. And also one issue that came out was that there's a lack of knowledge for the caregivers as a barrier. So as healthcare workers as midwife, as professional nurses, we are health promoters, so we can also help the health promotion teams within our different facilities to share this knowledge about the importance of vaccines. Can we give our doctor another hand, a round of applause? Thank you so much. So we are going to move to the next presentation, which will be delivered by Dr. L. Sobela on umbilical artery Doppler assessment project. Can we put our hands together as she's coming to the fourth?
That's for next slide.
Good morning, everyone. My name is Louisa Siopela. I'm an obstetrician. I work at Kalafongo Hospital, and I'm part of the University of Pretoria Research Unit for maternal, fetal, newborn, and childcare health strategies. Thank you for inviting me today. I must say I love the music. I like the vibe and the mood of everyone, and it's a pleasure to be here so far. And I will be talking to you about our project that we have been busy with. Okay, I must just remember that I'm doing two. So just as a bit of background, stillbirth continues to be a burden globally. Whilst the rates have been constantly declining in the past 2 decades, but they remain high. And about half of the stillbirths globally actually are from sub-Saharan Africa. And, but if you look at their contribution, the region contributes to about 30% of live births. So it just shows how much of an impact or of a burden that we have, and how much more needs to be done for us to improve the stillbirth. And if we look at the stillbirths, we have the ones that happen during the intrapartum period. In the latest stats from UNICEF, I mean, in terms of the ones that happens during intrapartum, they've declined from 55 to 46%. So which means something right is happening for management during labor to reduce the stillbirth that occur intrapartum. However, in terms of antenatal stillbirths, those, they indicate the quality of care that our pregnant women are provided, and more needs to be done to improve this. If we were to reach the target for the Every Newborn Action Plan of less than 12 per thousand stillbirths by 2030, indeed, more needs to be done. And I mean, there's a lot of guidelines from the WHO, and as well as our maternity care guidelines, which are really great in terms of risk stratifying our patients and taking care of them during pregnancy through to the postpartum periods. But we perhaps need to look at new or some innovations to try to get the rates down. So if we look at South Africa, most of the stillbirths that we get during the antenatal period, they fall under the category of unexplained stillbirth. And most of these occur in healthy, low-risk women, which it becomes a problem for us because we don't even know what to tell to the mother. And also for them, sometimes they indeed lose confidence in us because they have been attending clinic, and then this happens, and a lot of time we don't even have an explanation. But when they looked at this specific group of unexplained stillbirth, majority of them were actually low birth weight. So a lot of them were fetuses that were growth restricted, but were actually not detected during a pregnancy. So by definition, fetal growth restriction or restricted fetuses are fetuses that do not reach their genetic potential, their full genetic potential, and often it could be factors that are maternal, where maybe the mother has some medical condition which affect that, or it could be some fetal factors, but the commonest cause usually is the placental insufficiency, where the placenta is not functioning as optimal as it should. And a lot of this fetal growth restriction will either result in a preterm delivery, where the baby has to be delivered early, or in some cases where maybe the severe growth, if the severe growth restriction occur early, or in cases that they are undiagnosed, then they result in stillbirth. And a lot of these babies, if they are followed up throughout, even later in life, they have shown that some of them, they will end up with other comorbidities, such as metabolic syndrome, or even some heart disease. So the problem with growth restriction is mainly detection. So if we look at the stillbirth, it's more like it's just the tip of an iceberg, or in this case, we can just say the tip of a hippo. Because if you look at it, you have to think of all the underlying growth restricted fetuses that we actually haven't detected. So diagnosis remains a challenge. That's why we need interventions that will assist us to improve our detection rates. Several methods that have been employed to try to detect growth-restricted fetuses or fetuses that are at risk. It includes doing fetal kick charts to count fetal kicks. Most of the studies, they show that in terms of reducing the risk of stillbirth in low-risk population, they actually do not. But what it does increases anxiety of the mother, anxiety of the clinician, and now we end up with intervention, more induction of labor cases, more cesarean sections, and in instances, then you end up with more preterm deliveries. So it looks like you end up doing more harm than actually assisting. I mean, the other method that we do when we see our patients mainly is when they come in, we do the fundal height measurements. This is one we obviously have to accurately date the pregnancy, and then when they come in for follow-up, we use our graph to try to see if the fundal height measurement is in keeping with the estimated gestation. However, this method is not always accurate. We have instances where the mother has been coming to the clinic and they have been plotted throughout, everything plots normal, it is a stillbirth, and when we now assess the actual weight of the baby, we find that the weight was actually lagging behind. So it's not the most accurate method, and it can also be affected by factors such as increased body mass index, or in some cases it can be in patients who have like growth like uterine fibroids, or in some instances where maybe the baby is lying in an abnormal position, whether it's a transverse or an oblique lie. I mean, there are instances when two clinicians do measurements and you get separate measurements. So this just proves to show that it's certainly not the most accurate measurement. Ultrasound, some studies have suggested using routine ultrasound in the third trimester to try to detect growth restriction, but it really hasn't helped. And if we look at the ultrasound, because we are measuring the size, but if you do it at one time period, it will not help you. The growth has to be measured over time and plotted, and to see the growth trajectory of that fetus to see if they are crossing centiles or not. Because remember, we have the mothers who are small mothers, and then they will have the small babies. Those babies will not be at risk. But the problem is the babies that are destined to be, or were supposed to be big, but because of a placental or other factors, those babies, then the growth is actually start lagging. So now we are saying that perhaps instead of just looking at size alone, we should now look at function. If we could assess how the placenta is functioning, then that will be able to assist us. Because we have to remember that the placenta plays an important part in terms of gaseous exchange, provides the baby with oxygen, and remove carbon dioxide from the baby. Also in terms of supplying the baby with food, mainly like glucose, amino acids, those are for proteins, for fats, nutrients, and water, and also some hormones that also help to support the pregnancy. So in cases where this placenta is not functioning as they should, then the growth will be affected. So what we do with the ambiflow, ambi comes from the umbilical cord. So what it does is a Doppler ultrasound. What we do, we measure the umbilical artery flow to try to assess. That gives an indication of how the placenta is functioning. So basically, Doppler ultrasound, I mean, most of the conventional ultrasound machines do also have a Doppler ultrasound in them. It measures the frequency of waves, but the important thing is that it measures the resistance. So obviously, if the placenta is functioning normally, blood flow through the umbilical vessels will be normal, and when you measure the resistance will be normal. In cases where the placenta is not functioning as it should, when you measure the resistance in the umbilical artery, that resistance index will actually be high, and that tells you that the blood flow to the baby is affected. And in some severe cases, there will be even interruption in blood flow to the baby. And as you can imagine, if the blood flow to the baby is affected, then that baby will not grow as they should. So this is what we call growth restriction because of placental insufficiency. So this is how the ambiflow device look like, mainly, and then it's a small device, it's portable, and it's a low-cost device. It's actually locally manufactured by CSIR, and the important thing with this device is that then you connect it to a laptop. We are looking at also using a tablet to connect it to. But the important thing is that it also helps you to analyze the result. Because it's one thing knowing the measurements, but the measurements is not a constant measurement. Because earlier in the pregnancy, usually the umbilical cord is smaller, the resistance might be a little bit high, and that might be normal. But as the pregnancy advances, the fetus gets big, that actually the resistance in the umbilical cord normally drops, and as more flow is required. So what it does is that you do the measurements, but the app will not actually even allow you to do the measurements without putting in the patient details, which includes the expected date of delivery or a last menstrual period, so that you then have the gestational age. And when you do have the gestational age, when you do the measurements, then it will actually plot on it's like a traffic colors in terms of a chart. That then it will help you in terms of interpreting the results. So this test is done between 28 weeks and 34 weeks, and then that's the time that we screen with a bank plus. We usually encourage that when the patient comes for the 30-week visit, then they can be screened. Then that is also indicated on the file, because the patients will only be screened once. And then the ones that the measurement is below the 75th centile, it will chart on green. If it's between the 75th and 95th centile, it will chart on orange, and those ones need to be referred for a full ultrasound assessment within the next 2 to 3 days. And in cases where it plots on red, those ones actually require immediate referral. So if we're just looking at the evidence in terms of ambiflow, the initial work was done in Stellenbosch, and what it showed is that of the mothers that were screened, the ones who had an elevated or a high resistant index, actually it was associated with increased perinatal mortality rate. And when they looked at babies pregnancies where the fundal height measurement was reduced and they did ambiflow, it showed that it actually reduced the number of patients that they need to be referred higher up for assessment for suspected fetal growth restriction. After that, the University of Pretoria Research Center did a lot of work. One of our big studies on Ambiflow was at Mamelodi, where they screened 2,500 women, low-risk women, and what it showed is that it actually reduced the risk of stillbirth. When you compare them to the ones that were not screened, it reduced the risk by 40%. But also what it showed is that 11.7 of these women who are supposed to be low risk were actually found to have abnormal Dopplers, which then gives the question that why do our pregnant women who are supposed to be healthy and low risk, why do they have abnormal Dopplers, or why do they have stillbirth? And after that, there was the AMBI-9 study, which happened 9 sites in 8 provinces, and it also still showed these are the sites that the study was done in the 8 provinces, and what it showed is still the same, that actually it reduced the risk of stillbirth by 40%, and that about 13% of women actually had abnormal results, and about 1.2 had severe disease. And when they compare this to high-income countries, actually our rate of abnormal results was 10 times higher. So we don't know whether it's something maybe in our diet, or if it's, we are still trying to figure out why. And then in the international study, which was also led by UP, and it shows that about 6.9% of low-risk patients actually had abnormal Dopplers. And in terms of the ones with severe disease, it was in South Africa. But the other important thing was that the abnormal Dopplers were found across different centers. So it shows that some of these babies, if you only measured the size, you will actually miss the growth restricted fetuses. So from them, they looked at the pairs of 91 mothers and babies who actually had abnormal Dopplers. And when they looked at the results, they followed them up to 2 years. They showed that at birth, in terms of their birth weight and head circumference, the ones who had abnormal Doppler results was actually significantly lower. And this growth lag, persistent throughout, even up to 6 months. And even when they looked at them, when they got to up to 24 months, the growth, that still lagged behind. So what we have been busy with now is that the studies that I've told you about, those were done in a controlled study setting where we had a research nurse actually by the study who was actually doing the test. So now we've moved to a more like an implementation study. These are some of the facilities of one of our projects, which is Ambitswani. And this is in now sub-district 5, 6, and 7. And we've worked closely with the DCST team of Tshwane, who supported us very much, as well as the city of Tshwane as well. And just to share with you some of the results, that we have. It's not really results, but just to sort of give you this, we implemented from around July in 2023, and so far about 3,500 mothers have been screened, and majority of them, about 80% of them actually had normal screening, and about 20% of them actually required to be referred for further assessment. But what we do as well now is to monitor the DHIS data to try to see if there's any impact, which obviously will not happen overnight, but we know that we hope eventually that will show. So some of the challenges that we've had with Ambitswani is that unlike the other studies which were funded, this one we don't have any funding for it, and it's mainly supported by our unit. And what we have been doing is that we trained, and after training we have been supporting in terms of troubleshooting whatever problems that happens in cases where a refresher training is needed. And also there have been some difficulties sometimes in terms of the midwives obviously in cases where maybe the midwives moves around from rotations or in any where we have shortages sometimes. And we've actually had a few of the devices that were not working, that we needed to sort of wipe up the windows and reinstall it. But we also have a few that are actually, we have a probe that is missing or a laptop that is missing, which it is a little bit of a difficult since in terms of funding, we are a little bit on a limited place, which then it becomes a little bit challenging for us to replace those. And then as part of the project, we have Sibona Bantwana. With Sibona Bantwana, I mean, it's mainly to assess to try to find out in terms of why these women who are supposed to be, we are looking at patients who have preeclampsia, but also at patients who are low risk, who are healthy. We hope that it will give us answers to try to figure out why our patients who are low risk, who are healthy, why do they have placental insufficiency? But as part of Siyakubona project, some of the midwives that are here have been trained on the point of care ultrasound, which we trained about 500 midwives in 6 provinces. And as part of it, we actually now in 3 provinces, including in Mpumalanga and Western Cape, and as well as Tshwane, I think they got most of the devices. We selected a few clinics that are now trained on the AmbiFlow. So Tshwane is mainly in the sub-district 3 and 4, and we hope that this will show an impact in terms of reducing stillbirth. And so the main, achievements with this is that we know from our studies that AmbiFlow actually reduced the risk of stillbirth, and at the moment the main thing is to try. We are at an implementation phase study, which we will hope it will give information and also help in terms of, we hope that in the long term this could actually be adapted and implemented at a larger scale in South Africa. But obviously in terms of support from the managers and as well as the buy-ins from the midwives, that is indeed important for us. And we are still hoping that we could get more in terms of financial support, which will then give us freedom to do a little bit more in terms of the work. So what we also did, we created, because before we needed to go to the clinics to actually to see how they are doing. Now we've been working on a dashboard which helps in terms of we can see remotely how each clinic is doing. We are hoping that we are just refining it, but we will give the managers access that will help in terms of them seeing how their clinics are doing. Do I still have a little bit of time? 2 minutes, okay. Okay, I think I'm almost done anyway. Yeah, so this is just some of the, if you look at the graph, on the graph in blue, that's in terms of Tshwane district. You can see in terms of the stillbirth that they have declined from above 100 to somewhere hovering around 60. And this is the stats from April 2021, but it shows that more needs to happen for those stillbirths to actually go further. And if we look, the line-in rate, that's the target, that's the 12 per 1,000 stillbirths. And you see, if you look at the sub-districts, the one in green is for the sub-district 5, 6, and 7, and the one in blue is for the Tshwane district. But you can see our stillbirth rate is still high. More needs still to happen to get those rates down. So we hope that with the point of care ultrasound then can assist in terms of adequately stratifying our patients and also in terms of improving the dating of our patients, and that the addition of AmbiFlow in the 3rd trimester will assist in terms of reducing the stillbirth. And mainly this is our team, and headed by our director, Prof. Ute Vogt, who is a pediatrician and very passionate about maternal care. I always say to her that she is indeed an obstetrician by heart, even if she's trained to be a pediatrician. Thank you.
Can we give Dr. Sopela another round of applause, colleagues? Thank you so much, Doctor. That's quite an interesting study indeed. We just can't wait for our district and facilities to be part of this AmbiFlow studies. But in the meantime, what you've emphasized that as we wait for this project to be expanded, we just need to make sure that we take accurate LNMPs, make sure that all mothers are referred to our advanced midwives who are doing POCAs, the low risks, and also work with our hospitals, and also make sure that there's fetal kick charts in the maternity case records are completed, mothers are taught how to monitor the fetal movements. Without any further waste of time, colleagues, we are going to now invite the next speaker on the program. We have Dr. N. Taka. She's going to take us through mental health in obstetrics and why does it matter. Can we give her a round of applause? Thank you.
This is next slide. Yeah. Okay. Will I be able to see? So I don't think I'll be able to see. I'll have to can you flag it so that I can see? It's still morning. Good morning, colleagues. It's such a pleasure to stand here today. I must say you guys all look beautiful. Today is a very special day for me as a psychiatrist. Dr. Nokuthula Mdaka, I'm the head of unit for the district specialist mental health team in the West Rand. It's World Mental Health Day, colleagues. As a mental health practitioners, it feels like it's our birthday today. I'm seeing a few colleagues wearing green, well appreciated. I know midwives wear pink, so I'm actually noting the green. And I think it's so appropriate that we are going to discuss the mental health of midwives today. Deep down in me, there's an obstetrician. My two options were obstetrics and psychiatry, but the anxiety of being an obstetrician and the expectation of bringing that baby alive was just a lot to handle. And today I want us to really look into the importance of mental health for you guys as midwives. Initially, I thought I would speak about the mental health of the pregnant mother, but I think we forget at times the pressure that is on midwives and obstetricians, and how if your own mental health is not taken care of, you are going to struggle to then emotionally support a pregnant woman. As we all know, colleagues, this is a very vulnerable time for every woman. And not forgetting the family as a whole, the father of the baby, the family as a whole. It's a time where there's a lot of anxiety. It's the fear of the unknown. As much as you can see the baby on the sonar, you can see a lot of things, you know, and there's a lot of expectation from the team in terms of making sure that that baby comes out alive. Now, if you look at the meaning of the word health, I think when we think of health, we always think of physical health, that I don't have physical disease, right? And we forget the importance of mental health. The World Health Organization, you know, has this phrase that says, no health without mental health. And we've all seen how having a medical or physical illness impacts on your mental health, and we've seen how having a mental illness also impacts on your physical health. So the mind and the body work together. And it's key to take care of your mental health. If you can't think, you won't even remember to take that medication for a physical condition. But then when we look at what mental health actually is, right? So in terms of health in general, it's not just the absence of physical disease, but mental health in particular is looking at you being able to cope with normal stresses. So we all face challenges every day, right? And sometimes you find other people can't even cope with what is deemed normal stresses. Very difficult to define at times. But if you are mentally healthy, the expectation is that you can cope with challenges as they come. I just arrived now because I was stopped at like 4 roadblocks, right? So you would expect that I should be mentally well to be able to cope in such a challenge, and I won't end up turning back and just giving up, and so that's the expectation if you're mentally healthy. But also you are able to realize your own abilities. So you are able to realize your own strengths, even your weaknesses. Colleagues, it's so important to even realize your weaknesses, to say to your colleague, this is not my strong point. Can you manage that? That is actually a strength. But I think very importantly is that you can work well and you can contribute to your community. And as you can see, this meaning or this definition says you can function in all aspects of your life. And if you now have mental illness, then it would be the opposite. You can't cope with normal stress, and you can't function. And functioning is not just being able to work when you are at your workplace, but it's also functioning in the home environment. We find a lot of people are able to function in one area, but they're not able to function in another area. So for example, if you're struggling to cope or function at work and there's a lot of stress at work, it's going to filter to your home and vice versa. As I'm going through this talk, just want to request you guys to reflect internally on your emotional cup, right? How empty it is, or how full it is. The idea of this concept of filling up your cup is that your cup must be full, must be filled with nice coffee, creamy, however you like your coffee. I like mine black, no sugar, no milk. For someone else, that sounds like terrible, terrible coffee. You know, so what you think is your best cup of coffee, your cup, your emotional cup must be filled with that coffee. It must be outflowing, overflowing as well. Because that's what your patients and your family and your friends are supposed to be drinking. They're supposed to be drinking what's outflowing, and they're not supposed to be drinking from what is inside your cup. Ne? And your cup must also be beautiful. Ne? Don't use those cups that have cracks and they are even now black inside. So just imagine this beautiful a cup. And as I'm talking, if your cup is empty, I think mine, I poured a little bit out while I was speaking to the traffic officers. So if your cup is empty, just think of ways or things that help you to fill up your cup. So I thought to myself, what is a midwife, right? And there's this definition: skilled, knowledgeable, compassionate, and, you know. But the one definition that I liked was the one that says, it directly translated, it means with woman, right? And I thought to myself, sure, that is a loaded definition for me, because you are with a woman, right? So it says, it means you are with this woman and you are helping them out through the whole pregnancy process. And remember, it starts preconception, right? There are people who come in and say, actually now I want to have a baby. And it even goes beyond a pregnancy with the postpartum period. And you are literally with this woman. What a big responsibility, you know? And emotionally, I wonder how much emotional support and mental health support midwives actually get, how much of your training focuses also on your mental health and not just the mental health of your patients. And there's also this giving of yourself, right? You can imagine you are helping women to get into this beautiful moment of families of having a baby, and you are working night duty, and you've just come back from maternity leave, right? If it's a male, you only had, 4 days of paternity leave, and you are helping another woman to receive this gift when you've left your gift at home. That's a lot of pressure, okay. This is quite long, but it's an extract I took from an article where they were looking at the mental health of midwives, and this was quoted from the interviews of one of the midwives. And really what is coming out of it is her expressing the physical symptoms that she gets from struggling mentally. She mentions the poor support, and not just in terms of resources, but support, emotional support for the team. When we do our M&Ms, colleagues, maybe show of hands, do we touch on if maybe there was a fetal death? Do we ever pause and ask the team that was involved how they felt? Okay. Midwives, show of hands. Okay. I'm sorry to trigger you, colleagues. But so those are some of the Thank you, colleagues. I'm so sorry to trigger you. Yeah, my job as a psychiatrist is to get people talking. And those are some of the, small interventions we can put into our daily working structure. In the morning, before we start with delegation, let's have a mental health moment. Before you take over from the previous shift, let's do an emotional check-in. Let the M&M start with an emotional check-in and maybe end with an emotional check-in as well. So just reasons why our mental health matters, just in general now. Now we're not even talking about midwives being a high-risk population within healthcare workers, right? And I think COVID has really helped us because our mental health was put in the forefront globally as healthcare workers, particularly the mental health of healthcare workers who are what I like to call first responders, so emergency departments. But I think sometimes midwives are not seen as those first responders. When we think of our emergency departments, I think we don't think of the MOU or the obstetrics ward actually being an emergency department. Because as we know, pregnant women don't go through the main, they go through, which means it is an emergency department and you never know what you're going to find. So what we know, the latest stats, they say 1 in 4 people in South Africa is experiencing a mental illness. So if I were to do that in this room, that would be 25% of us in this room. If I were to say show of hands, who's feeling a little bit edgy today, who struggled to sleep yesterday, I will be starting another discussion. So I'm not even going to go there. Okay. So in the workspace or in your space, colleagues, we know negative impact, right? On health outcomes, all of these indicators that we are expected to achieve. If you're not mentally well, your thinking is affected, it's going to impact on the quality of care that you can give to your patients. But what I've found even more, not more important, but the impact it has on the relationships that we then have with each other in the team is really, really quite significant. But colleagues, don't forget the overall quality of life on you as well. So why are midwives sort of seen to be more vulnerable, right? Long working hours with intense physical demands, like physical demands. If there is a baby that you are struggling to deliver and you have to use other methods, you need to be physically strong, right? So the demands are also there physically as well. High pressure environment, the high stake environment. Hey? No one wants to lose their baby, right? It's a precious life. So you may come in there already having pressure to perform, and that pressure can impact negatively on you. There's also emotional pressure, the workplace challenges. Colleagues, we all know we are working under constrained resources. The emotional toll on difficult cases, as we touched on earlier around the M&M. And what we found is that a lot of midwives, they carry their previous difficult cases, right? There's trauma that is experienced at work. And when you interview a midwife, they go back to cases of 10, 15 years ago. So there is that constant trauma that is actually building up and is not dealt with. Okay. So then in terms of the mental health impact of all of these challenges that I've mentioned, burnout. I think a lot of us have suffered from burnout. And burnout is not just, I'm not interested in going to work. It's not just being tired. I think a lot of times when we think of burnout, we think, I'm just tired. It's year-end fatigue. But there is a huge emotional dysfunction that is attached to burnout. And unfortunately, it does lead to that decreased motivation, right? And very often as psychiatrists, we say, it's not burnout, it's major depressive disorder. Let's just call it major depressive disorder because you actually cannot function. And then we know that anxiety and depression is very common amongst healthcare workers. But like I said, midwives, obstetricians are even at high risk within the healthcare worker population. And that's secondary traumatic stress. So some of it is not directly your trauma, but it's also the trauma that you are hearing from your patients. It's the trauma that you are experiencing at work. Now, what can we do about it? Going back to our CAP, we firstly need to recognize the symptoms. You need to recognize that you are struggling to cope at work. What we find is that most professionals, they don't express sadness. So when you read, you'll be told depression, you feel sad, right? Most professionals don't feel sad. What we see mostly is that difficulty with finding pleasure in things you previously enjoyed to do. I think midwifery is a speciality where you will hardly get someone who's in it for money, or it's a field where you mostly get people who are there because of the passion. So when you start to see a colleague losing interest, you know, making what we can even see as silly mistakes, you know, and there's that change in how they used to perform. It's not just always about performance that you must manage. There's that element of emotional challenges that they could be having that you need to manage. So as individuals, we should be able to pick that up in ourselves, but also it's so important to pick it up in other people as well. And I think for those who are sitting here who are managers, it's so critical for you to be able to understand what burnout is, what depression is, so that you can pick it up quickly even in your team. You need to set clear boundaries between work and personal life. In your personal life, I'm smiling as I'm saying this because, you know, it's such a difficult thing to do when you are a healthcare worker in a profession that is deemed a calling, you know. Midwives are called at home. If the community knows you're a midwife and someone gives birth at home, you are going to be called in your community. Okay, so those boundaries are important, colleagues, because then some of you will never knock off. So we have to set those clear boundaries. We have to learn to practice mindfulness and learn relaxation techniques. I mean, ideally, our tea rooms in our institutions should be places where we are able to practice some of these relaxation techniques when we are taking our breaks. We need to seek peer support. The cases are difficult, so we need to start to also seek support of our seniors. Colleagues, I know I've triggered you guys to want to talk about your mental health. But I'm about to wrap up. There are a lot of professional mental health services that are existing now since COVID-19, and I will share the contact details. We need to access those. I know there's stigma, colleagues, and the sad part is that the stigma amongst us as healthcare workers is scary, and frankly, it's embarrassing. It's so embarrassing to have a nurse say to you, don't you have a sick note that does not say that you're a psychiatrist? Because I'm ashamed. I know, I've heard and I've seen how colleagues who've been admitted in mental institutions or in wellness institutions, the comments that then fly in the unit when they come back, the labeling. So I think, colleagues, it's very important. It has to start with us and how we treat each other when we come back with a diagnosable mental illness. I always say we are all mentally unwell until proven otherwise. And days are not the same. Ne? Seasons are not the same. This may be my good season, but when it's not my good season and it's your good season, you should be able to carry me through that difficult season. I think as I close off, I want to just remind us colleagues that we spend so much time in the workplace. You can't help but have your colleagues become your family and friends. And the relationship we end up having because of the situations we go through at work is quite an intimate relationship. So if I've had a tough night, chances are I'm going to express it to a colleague. So we need to be gentle to each other. Okay. So I've flagged some of the mental health resources in terms of getting help. I think sometimes we underestimate that people still don't know where to get help. And then just to close off, I just want to quote from Ilana Brown. She says, rest and self-care are so important. When you take time to replenish your spirit, it allows you to serve others from the overflow. You cannot serve from an empty vessel. Thank you, colleagues.
Thank you so much, Dr. Mdaka, for your beautiful presentation and also reminding us as healthcare workers that our mental health matters and it begins with us. Before we reach out to patients, let us practice self-preservation. Amen. Can we give her another round of applause? Thank you so much, colleagues. I think my journey with you is gonna have to stop here. You've been such a beautiful people. Thank you so much for the positivity, the positive vibes you are sharing there. Thank you so much. You know, when I agreed to facilitate, I didn't intend to facilitate. So when my manager told me I'm a very shy person, yeah. I agreed because there's a channel on YouTube that promised us something. September the 23rd and the 24th. And it didn't happen, so I just had to come and stand here. So yeah, colleagues, I'm going to hand over the program back to Miss Yolanda. You didn't hear about the 23rd, colleagues? And there was another postponement for the 7th of October. We are still here. I thought I was going to go, you know, to the higher realms up there. But yeah, we thank God. As we go back home, we hope the conference has really done us good, colleagues, especially myself. My compassion, my love, my respect for patients has been reignited. And we are so grateful to have been part of this, where iron sharpens another irons. And we saw very powerful speakers fixing our crowns as women. Can we go back to our facilities and not get tired of doing what is good? And may the good Lord pour his grace on us. May he strengthen us so that we can mount up with wings like eagles, running and not being worried, and walking without fainting. Ms. Luther, thank you so much. Over to you.
Thank you very much, ladies and gentlemen. And so we are coming towards the end of our fabulous conference this year. We look amazing, and after an amazing 3 days, we need to wrap it up by an amazing person. So we are very fortunate to have in our midst our acting director, Mrs. Tanashi, that will come and give us the provincial plan and the way forward after these 3 days. Thank you very much, ma'am.
Then it moves the slides. Okay. I did. No, I have only 7 slides, so I'll be done. Okay. What's the time? Good afternoon, colleagues. Okay, we are wrapping up the slides. We are wrapping up, colleagues. Okay, thank you very much. I'm just going to give a way forward regarding the 3 days seminar that we had. And mainly what we looked at our theme that was talking to all of us, that was saying to us, nurses and midwives, critical in every situation. And the sub-theme was talking to empowering nurses as catalysts for quality maternal, newborn and child health. And when I looked at the theme and the sub-theme, I immediately matched it with the 6 key priorities of the Department of Health, where we are requested to improve the patient experience of care and also to improving clinical services. So it is our responsibility to do that. We need to be informed. And how do we then get informed? It is during this very 12th MONEC conference, which was the one of its kind. And we hope that from this conference, every nurse or midwife that gathered here was able to, and those that were attended online, were able to be empowered through the presentations that were presented in the past 3 days. And the sub-theme, you must take it home and also look at it. It was not just chosen just as an immense meaning, but to reaffirm the position of nurses and midwives in our society. And this conference presented all issues that are contributing to maternal, neonatal, child health and mortality and morbidity, which then tasks us to go back. Remember, we were giving the problems, and on the other hand, we're also giving solutions. So we are then tasked to go back and look at the presentations that were guiding us on what needs to be done. So that is where we are then supposed to be looking at all the things that we're going to put back into our situations for us to be able to reduce all the avoidable deaths through the various presentations that were done. And all presentations were presented not only to show knowledge, but also to empower all the clinicians that are gathered here, that you must learn and go and regurgitate that and be able to implement it. As we are all implementing evidence-based information, it is then very important for us to be able to improve patient care. There is so much that you are doing, colleagues, and whatever you are doing, it is recognized and it is seen. Don't think that we are not seeing. From all that we are saying, we are just saying we can then do much better. So whenever we're engaging on issues, we must always strive to achieve all our best. And then this is the time when we are trying to encourage every one of you not to give up, and also to look at the calling that you have accepted. I always say to people, working with patients, it's not just an issue that talks to interest, but it is a calling in a way. Look at the calling that you have chosen for ourselves and go and implement. And your efforts cannot go unnoticed due to the oversight that is pulled through when we're reflecting. And we are performing as a department. We are having gaps as a department. And we fully depend on you that we are able to implement all these things that we were taught today, and you'll be able to change the lives of the people out there. And the vigorous dialogues that took place here, I know some of us were very angry when they were being presented. The dialogues were talking to us that we need to look at introspection. One of the people from SANC was saying, they are not here to protect the nurses, but the communities. So I think we must then go back to the drawing board and ask ourselves, as we do things, who is going to protect us? And that we'll only be able to do if we're reflecting on all the good things that we do. Okay, the Department of Health is still having a problem with the curable burden of diseases. And as the neonatal, maternal, and child health, we are leading with the problems. So it is up to us then, colleagues, to go back and look at it. What is it that we're doing as the department to be able to reduce all those mortalities? This includes health of mothers, children, and newborn. It is then critical to ensure survival, development in the early stages of life to those ones. And then Gauteng has made noticeable progress in the maternal, reproductive health, and ANC access and maternal and child mortalities. It is not saying that we are not doing well as the department. We are, but we need to do more. We are cognizant of the fact that we cannot exclude NCDs, TB, HIV, and AIDS, and mental health. Colleagues, we have had how many mothers are dying, maternal deaths that we had due to mental health. It is therefore very important for us to look at these factors and also try to address them, because we are trying to decrease the infant and mortality and maternal mortality rates. On day one, we reflected on the Saving Mothers report, and then it also talked to the 4 leading causes of death, and NCDs, that is hypertension, was one of those. So there was a recommendation that we develop the SOP that is going to be initiation of aspirin as per the latest EML guidelines. And it is then going, as the provincial office, we're going to look at that, because we cannot be still talking about mothers that are dying because of hypertension. And they also talk about the issues of hemorrhage as the leading cause of death in mothers. So we're also looking at the implementation of the emotive and the calibrated under the buttock drape. So it is very, very important for us to look at those, because they are on the e-catalog, colleagues, that is going to assist all districts for them to be able to do what is expected, for us to be able to detect the postpartum hemorrhage earlier. And for us to be able to procure all these things, we need to be incorporating them in our demand plans. Can we then do as expected, colleagues? And then the contraceptive uptake, which is the main leading thing of the unwanted pregnancies. Limited TOP facilities, limited second trimester TOP facilities. And if we are not driving the issues of contraceptives, we will still be having a problem with Section 27 knocking on our doors, because of the backstreet abortions. So it is very important, colleagues, for us to be looking at that. Unfortunately, people were talking about the distribution, were talking about the IEC materials. We are having 2 companies that sent documents to us to look at. They'll be forwarded to all the health districts for you to comment on them. And if we agree on the comments that are going to be given, we will definitely be having IEC materials. But let's remember, the IEC materials are not going to be driving mothers to come into our facilities for the contraceptive uptake. And we are then going to be looking at encouraging mothers to go on the long-acting contraceptives so that we increase the coverage. If we fully depend on condom distribution for contraceptives, on the couple-year protection, we are then killing ourselves, because the sooner there is shortage of condoms, then the couple-year protection rate drops. So it is then very important for us to be looking at all the things that need to be done. We've noted an improvement in PPIP reporting, but there is one thing that we must then do. Remember, it was fairly stressed that we're having 2 districts that are doing very well in submitting, and that is the West Rand Health District and the Tshwane Health District. And those 2, the districts that are not reporting as expected, can we please, colleagues, try and do that, so that when the 2024 NAMPKEMCO report is going to be compiled, our facilities can also be incorporating. PrEP in pregnancy is another area. And I'm going to also link that with the issues of triple elimination. We must then be taking good of those children, because if we are not taking the issues of giving mothers PrEP and triple elimination, we end up having a lot of children that will be presenting with HIV. And if they are undiagnosed, they end up dying as severe acute malnutrition cases. You have seen the influx of legislature questions that we're having, that we're talking to severe acute malnutrition. And most of those cases are children that go to health facilities and they are not being picked up as having HIV. So can we please try and help to decrease the viral load in those mothers so that we can encourage them to breastfeed and the children are going to be safe. Cervical cancer screening. Oh, sorry, colleagues. Cervical cancer screening is very critical, as we know that cervical cancer is the 3rd most common cancer causing women to die, yes. Last year, we implemented the issues of HPV DNA testing, and it is then important for us to try and drive that to be done in our health facilities. HP viruses, not only cells. So it is then very critical for us to do the cervical cancer screening, for us to be able to reach the 40%. We're having a lot of mothers that fall within the category that needs to be screened going to our facilities. But if the provider-initiated method is not done in our facilities, we'll end up having all those mothers not being screened for cervical cancer, and they end up dying because of cervical cancer. And the other thing that is also very critical, colleagues, we're having pink drive going to health facilities that is doing screening. It is embarrassing then for us to be having pink drive colleagues coming to our health facilities and they don't get any mothers that needs to be screened. So if we know that pink drive will be coming, let's try and do mobilization of our mothers so that they can come to our facilities. A lot have been spoken about the issues of vaccine hesitancy. And that on its own, it's the main leading. Oh, sorry. Technology, okay. Okay, yes. And this vaccine hesitancy, it is affecting the performance of all our immunization, I'm saying all, our immunization coverages. So it is then very, very important for us to try and do, my past chief director used to say we must talk to game changers, okay? whenever we go to narratives, we cannot be saying as a narratives, we are not achieving because mothers are not coming to health facilities. We are not achieving because when we trace them, we don't find them. So I think we need to go back and look at what is it that we can do for us to be able to attract more mothers to be coming into our health facilities for immunizations. Because okay, thank you. Because if the vaccines are not given to the children, we're going to have a problem of the outbreaks that we're having in our communities. So it is then very important for us to look at our catchment population and ascertain that all children are being immunized. The presentations that were done here were also talking to HIV retesting and PrEP and contraceptive services. So it is very important for us to try and go and implement whatever was discussed. As the Department of Health, we have never had a clean audit. And for us to have a clean audit, it fully depends on us. So that is why Mr. Mwepe yesterday spoke to us about when we talk to our colleagues, we must ask them what is it that they did in the files for us to be able to get the clean audit. So, colleagues, this then brings us to the end of our recap. Thank you very much. See you in 2026.
Thank you very much. Thank you, Ms. Nomonde, for that lovely way forward. And yes, 2026, I think it feels like yesterday when we said see you in 2025, and here we are. Ladies and gentlemen, as you felt in the mood of today, it's very calm and quiet, more or less like myself. That's why we are listening to soothing music, maybe some Barry later on, maybe some Tenny Pendergrass maybe later on. It would be lovely. But ladies and gentlemen, now we are coming to the nice things, the things that normally I stand in the back and I'm the wallflower. We're going to have the award, the presentation of the awards now. And now we can let loose, and there will be nobody that will make you subdued. So please have a warm welcome to those that will be giving us our presentation of the awards. Thank you very much.
Yo. Ah. Yeah, ne? Ladies and gentlemen, thank you very much for such a warm welcome. Good afternoon. You can do better. Good afternoon, ladies and gentlemen. That's more like it. Thank you very much, ladies and gentlemen. It is that time of the day. It's exactly 12:40, the time for the 12th annual MONEC Awards held here in the Sidibeng District Health Services. Do you guys know where you are today? We are here at the Val University of Technology Conference Center. For those who did not go to university, let's meet today. Today, ladies and gentlemen, we are recognizing the heroes of healthcare. We proudly acknowledge the tireless dedication and exceptional care provided by midwives and nurses worldwide. As catalysts of change, they drive progress in maternal, neonatal, and child care. And today, ladies and gentlemen, we celebrate their outstanding contributions and commitment to delivering compassionate care. Excellence in midwifery, excellence in nursing practice, innovation in maternal care, and outstanding contribution to neonatal care. Let us give them a big round of applause. Hey, we nearly made a mistake. Let us now introduce ourselves. We nearly continued with our program and forgot to tell you that well, I know that English says ladies first, but I'm going to start today because I am the head of the house. Again. So, ladies and gentlemen, my name is Mr. Brian Mutaung, the one and only in Val. I am the third generation of the rich people. It's Ntate Thuso Mutaung, Ntate Kaiser Mutaung, then I'm coming. And colleagues, as usual, I'm not alone. I'm here with my colleague, a princess, a stunning lady, a nurse. My lady, please introduce yourself.
Good morning once again, ladies and gentlemen. My name is Neo Libito, a midwife specialist working here in Sidibeng District. We will be doing the ceremony. So please, ladies and gentlemen, with standing ovation, let us welcome on the stage the Acting Director of Maternal, Neonatal and Women's Health, Ms. Nomonde Danase, to give us the purpose of this segment and hand over the awards to our dedicated midwives and nurses.
Yeah, I am. Oh. Thank you very much, colleagues. To the acting chief director, the chief directors present, the HODs, clinical managers, and the CEOs of the hospital, and all delegates that are gathered here, protocol is observed. To our delegates, midwives, child health care in Gauteng, we honor your unwavering dedication to maternal and child health. Your expertise, compassion, and tireless effort have transformed lives. As guardians of care, you empower women and families. We celebrate your excellence and commitment. Thank you for being the beacon of hope and care in our communities and in the province. With those words, as the Gauteng Department of Health, Maternal, Neonatal, Child and Nutrition Program, may your passion and dedication continue to inspire and uplift the communities you serve, and you may be celebrated many more years to come of life-saving care and compassion. I thank you.
without wasting time, we would like to call upon the stage the Deputy Director of ISHP and AYFS, Ms. Marosi Mzondi. The district team representatives, the DD, the AD for Maternal Health, DCST. The district, sorry. City of Johannesburg, sorry. Okay, ladies and gentlemen, how we're going to do this, the City of Johannesburg is going to use that exit and then they're gonna come in walking through the red carpet. Thank you.
My selector, please call the 011 girls to come and take their medals. Pina yako 011 iring. Banyana bako Small Street. Banyana bako Hillbrow. Banyana bako Maboneng. Ke kopa le ba opele matsoho bathong. They'll be the first ones to walk on the red carpet after us. Halala 011 halala. My selector, I know there's a problem with sound engineers or sound people. When you say to them, my selector, they don't understand. Okay, DJ. They're used to being called DJ. DJ, aumpitetse banyana bako 011 da. Aha! Ska! Yo. Ali di tole sa jive. Jive ang guys. Yo. Yes. Ini list tidak. I didn't know that there's a gold carpet. I only know white carpet, red carpet, black carpet. I saw Kasidibeng, man. Ay, 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 ay. Ay, 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 ay. If it's my first time seeing a gold carpet, I know lelona la kala we bona mo Sidibeng mo. Gold one. So while they are still fixing the floor, ladies and gentlemen, we are now going to call upon the next district's representatives. That would be Eguruleni district. Banyana bako Nigel. Bako Duduza. Babot Akani. Banyana bako Tema. Kiyo ngwanyana ko Tema. Banyana baka Jenu. My selector. Aure bitetse banyana bako Tema le bako Duduza.
Thank you. Thank you so much, Ekurhuleni District. Now, we are going to call upon City District. Thank you.
Sakena di host. Bakena banyana ba fal. Banyana ba 016. Banyana ba 3 River. Sakena di host. Aha. Yo. Suka. Bakena banga ba red carpet. Banyana ba ko Vanderbijl Park. Ba ko Vereeniging. Banyana ba na le di state of the art clinic. Zone 17 clinic. Banyana ba bo Levi so. Banyana ba bo Randval. Everything has Val. Banyana ba ko 016. Banyana ba ko Sharpeville. Banyana ba 21 March. Banyana ba Sharpeville Massacre. Kopa le smiling hle batle lona.
Thank you so much, Citibank District. Now we are going to call upon Tshwane District.
Banyana ba mma. Banyana ba bosesi. Banyana ba stepe. Banyana ba capital city. Banyana ba O12. Ba re he ba ipitsa ke megwanti ya Pretoria. Banyana ba stepe. Ba stepe sa national. Banyana ba mo tšhelete e etsuwang teng. Thank you, DJ. Thank you, my DJ. Trying to save time. Thank you very much. Tshwane, come through. Aha. Bosesi.
Thank you so much, Tshwane. District would now like to call upon the West Rand District.
Banyana bako Western area, bako Mtlakeng, banyana ba Sibanye gold, banyana ba Tshwereng gold, banyana ba R28, banyana ba ko di mining, ba health and safety, banyana ba midwifery and OHS, Manesari overall, come in, relay mates, yes girl, with the purple dress, yes girl, Naile walk, Bona slender seta, suka, hi man. You are intimidating the others, ladies.
Thank you so much, Western District. Now we are going to call upon the provincial task team, starting with our very gorgeous chairperson. Thank you.
The planners of this event, the stage is yours. I soka miska. I soka man. Now is the time for our bosses, the owners of email addresses, those ones who will email you on Friday at 4:05. Provincial task team, let's save time. Boss ladies, starting with the chairperson from CD Bing, I soka man. The lady with the golden dress. Woo! Chesa. Cherita Khale. Yes. Kavale walk. I soka man. Banyana bari email address. Banyana ba 45 Commissioner Street. Podium 2, podium 3, podium 4, 19th floor. Banyana bari appointment. Banyana bari slides, little presentation. Banyana ba no man tunko moral oko. Banyana bo plena event ele banyana fela. Banyana ba Beachwood Hotel. Girls that speak English from Curo. Banyana ba di access card. Head office. Head office ite. Then we do. Head office yare deadline. The intellectuals. Batho ba tshwereng di-sponsor tsa Gauteng kaofela. Batho ba phesa le e typiweng. A ya ngolwa ya bona e typiwe. Batho ba na leng di-shares ko GEPF. Ladies and gentlemen, thank you very much. Ms. Carr won an award. Doctor, please assist. Ms. Carr? Me Mzondi, me Tanase, Ntate, Mashamba, ifang red carpet msebetsi. Kala man, litle so. Wena doctor we me mua honest. Me Pepe Nene, our acting director in CDB. My selector, Mpitse Tsebon. And then I can shake their hands. Why not? Can somebody assist the doctor here? The doctor. The medical officer. Ladies and gentlemen, please give it up for our provincial bosses. Accession. Aha! Oh! Baba atle o ka re ba bereka sedibeng. Ba batle ba tshwana le West Rand hanyane. But sedibeng se ba tshwanela. Ladies and gentlemen, please give it up for the one and only Dr. Gaugelo Molefe from CDB/province. Aha! Wanyana waka zone 14. Wanyana wa Sebokeng wa 016. Wanyana also number 1 ko Vets. This is when they moved Northwest University from Northwest by Tlisa Koval. That was after her. Sharp. Thank you very much to our acting director and our colleagues from different districts. Now we are coming to today's presenters, the owners of the slides, the ones that were telling us about the immunizations and ladies and gentlemen, please give it up for them. All presenters today, please take to the stand. The presenter, tsa ko SABC. Batho ba o robala ka 4 a.m. preparing presentations. The specialists, the advanced. My selector, Mpitse Tsebon. Presenters, come in. Thank you very much. All right. Thank you very much, ladies and gentlemen. There's a special request from province. You know when province requests mus. Now it's the time for the media team, the mid husbands. We just gave the midwives their awards. VUT team. All right. First, we are going to start with the VUT team, the owners of the conference center, to all come and be honored. VUT, oh, you are here. Lea Short. My selector, can you please call VUT for me? But the higher institution. I nearly said, Mr. Chancellor, but today is not your platform, guys, it's ours. Higher learning institutions. My selector, I'm Peter VUT da. But we're NS fast. Thank you very much. Thank you very much. Ladies and gentlemen, Province Buile, I'm just going to interpret what they've just said. They said now it's our time. Me and Sister Neo. So Sister Neo is going to get her second medal. Or she says she's okay. So now it's my time, the meat husband. I'll walk on the gold carpet, it's fine. Okay, there. Then come this side. But I still want the gold one. Kopaleng kopele matsoe. You know how it was Zone 7? Who knows Zone 7? I'm the first one to get this medal from Zone 7. So now, I've just seen the importance of school. I'm going back to school. Next time, I want a trophy, the big one. Ladies and gentlemen, let me not waste time. Now, we are going to call upon the media team. Bana bantzimba bantlhaisa mona. Ene ba lebetse ke ya Newsroom Africa there. So the media team, please come and get your ntonton. Media and communications. Bateng. I saw Katabang. I'm Fanak. Yeah. Yes. Media team. Thank you very much, ladies and gentlemen. Can we please give our provincial officials another big round of applause? That, ladies and gentlemen, brings us to the end of our award ceremony. But I've got a challenge for you guys. Quickly before we conclude, I guess every one of you guys has a smartphone. Am I right? I need every one of us to take out their smartphones, put them on selfie mode like this. You see? Are we ready? And then take a picture. No. I want us to start all over again. I want you to take the best picture with all the filters. Are we done? And after that, open that picture. Tell the person you see that, congratulations, you've made it this far. Thank you very much, colleagues. That brings us to the end of our award ceremony for our 2025 MONEC conference. Thank you.
Thank you so much, ladies and gentlemen. Now we'll be handing over to Ms. Yolandi. Thank you.
you, ladies. Thank you very much, ladies and gentlemen. Thank you. That was just too beautiful to not let it go on a bit. Thank you so, so much. That was fun, eh? That was very, very lovely way of ending off this fabulous 3 days. Ladies and gentlemen, we just have 2 more formalities to attend to before we reach our closure for today. If I may ask Ms. Motswega to please come up to do the conference survey and the evaluation forms, please. Thank you.
Good afternoon, ladies and gentlemen. Hi, no, Sidibeng. Hi, no, I'm out of words, levels. Every year we're moving from one level to another. The pressures, Johannesburg. Colleagues, let me do what I'm assigned to do for this afternoon. I believe we have all received the QR code. I'm not social media. Can you kindly display the QR code for us to evaluate this conference? Colleagues, we rely on you so much so that we know what else do we need to work on. So kindly do go through the evaluation form. Tell us, give us feedback. Tell us where didn't we do right so that we can actually do better for you with the next conference. So you just, for those that do not have, you use your smartphone, the camera mode. Some of us, the camera mode takes us straight to the form. If you do not have, then you need to go to a portion in your phone where you are able to scan a QR code. And then there you will find about 10 questions. They are not a lot. It's only 10 questions for us to evaluate. Colleagues, I'm worried. I want to see everyone on their phone. The phones are dead. Can we kindly evaluate the conference? Do you need any assistance? If you do need assistance, please raise your hand so that we can assign the task team to come and assist you, those who are techno-savvy. Can you kindly assist Ms. Nadi, please? Okay, someone is coming for you. Colleagues, are we all good? Do you need any assistance? Please raise your hand. We good? Okay. Let's evaluate with our fingers, colleagues. Let's evaluate with our fingers. Our mouths, they were on a break. Thank you. Are we winning? Tabang, how far are we? How many have evaluated? 23. 43, colleagues, let's evaluate. 43 have evaluated. It's me standing in between you and lunch and going home. Can we kindly evaluate? Tabang, how far are we? 58. It's only one district, colleagues. It means one district evaluated. 4 more districts to go. DJ, can we kindly have a little bit of motivation? Tabang, how far are we? 107. Thank you so much. 2 districts, colleagues. 3 remaining. Please do not be discouraged. Do evaluate. It helps us with the next conference. Thank you so much, colleagues. So far, it's 3 districts that have submitted. May we will just continue. DJ, thank you. Thank you so much. We will continue with our evaluation forms as the program drives towards its conclusion. Thank you so much. Please be encouraged to continue doing it. If your phone is off, when you get home and you have charged your phone, please do evaluate your opinion, your advice, every word that you'll be typing there. It is of utmost importance, and we as a team will go through each and everything and see what is it that we can improve. And besides that, I think most of the things were top-notch. So for this conference, we're moving. So the next one, pressure, will do better. Thank you so much.
All right, ladies and gentlemen, thank you very much for that. The second last thing that we need to do today is to do the acknowledgement of the speakers, the attendees, vote of thanks, and the announcements, which will be done by Ms. Penene. See, now I'm getting her surname wrong. She's going to kill me. Yes. Thank you very, very much. The floor is yours, ma'am.
Okay. Thank you very much, colleagues, and good afternoon. Mine is very much easy task that I've been given today is to acknowledge all stakeholders who participated in this marvelous 12th MONEC conference. And indeed, I just want to indicate that Inkosi is Petegeneba. And Mohaua Hai kan nete or apesite matsatsing ana a mararo a fitileng. Firstly, I would like to acknowledge him, our Almighty, in making these 3 days of this conference possible. Because if it wasn't through his mercy, we wouldn't have made it this far. I would also want to acknowledge on behalf of the Department of Health and Wellness, the 12th MONEC 2025 hosted by the Sidibeng District Health Services. I just want to extend our heartfelt gratitude to the Department of Health for their invaluable sponsorship in supporting this conference. As our esteemed employer, their support has enabled us to convene this pivotal event, advancing maternal, neonatal, and child health. Thank you for investing in our collective pursuit of improved health outcomes. And I will also acknowledge the presenters that has presented to us in this conference throughout the 3 days. And their expertise and insight were very much valuable to all of us. And I believe that we have learned and we have a lot of messages that we have taken home today. And this we are going to implement. We are not just going to take them home and not make use of it. Your outstanding presentations have enriched our understanding and inspired meaningful and expanded the knowledge and skills to all the delegates. Thank you very much. And to our sponsors and exhibitors, I would also like to extend our sincere thanks to the following esteemed organizations for their valuable contributions in ensuring that the 12th MONEC conference is indeed a success. Your support has been instrumental in making this event a success. We are grateful for your commitment to advancing maternal, neonatal, and child health, as they are indicated on the slides. Thank you very much. And we hope in future you're still going to do that for us. We sincerely appreciate your exhibition for their valuable participation in the Maternal, Neonatal and Health Conference. Your innovative solutions and products have enhanced our event, providing attendees with valuable insight and opportunities for collaboration. Thank you for contributing to the conference success, and we hope in future we'll also hold our hand as we proceed with our conferences. To MONEC delegates and healthcare professionals, participants, we extend our heartfelt thanks for your active engagement, invaluable contribution to the Maternal and Health Child Conference. Your presence has enriched our discussion, inspiring collective in improving health outcomes. And also, the task teams from the province and all the districts, they are also being acknowledged today. Thank you very much and well done for the job that has been done today. With all those words, I thank you all. And I will leave the stage with the midwifery way. Until I reach my goal, until I reach my goal, I will never depart from the golden rule until I reach my goal. I reach my goal. Until I reach my goal, I will never depart from the golden rule until he says, well done. He says, well done, until he says, done. I will never depart from the golden rule until he shakes my hand. He shakes my hand until he shakes my hand. I will never depart from the golden rule until he shakes well. Thank you. My apologies, colleagues. I forgot the very important people, VUT, who has hosted us today. And then next time they'll kick us out if I don't acknowledge them. And if it was not for yourselves, colleagues, I don't know what the Sidibeng district would have done. Please bear with me and my sincere apologies on that. Thank you very much for hosting us. Thank you.
All right, ladies and gentlemen, before we say our last goodbyes, you'll see on the program there is, just after the last esteemed speaker, photo shoot. So ladies and gentlemen, outside there's a photo booth, and I was told to ask that the task team and the districts get together there so that the photos can be taken. After that, you are more than welcome to proceed to the lunch. But before we do that, ladies and gentlemen, if you can just afford me just a second to say thank you from myself and all the dignitaries that is present today. Thank you for everybody of you, everybody that we've already said thank you to, but thank you to each and every one of you that has made the last 3 days a success. Till 2026. Till 2026. That's in Joburg. That's drive safely. Thank you, everybody. Mr. DJ, make some noise, please. Thank you.